family to notify them that Chesang had disappeared from the hospital. His body would be found outside the hospital's compound, mutilated, without both hands and both legs. Just a week before Chepkemoi received news of her brother Albert Chesang's disappearance, they had admitted him at Moi Teaching and Referral Hospital, Eldoret. Chesang had throat pains for some time and could barely eat, surviving only on milk and porridge.
Wakachukua sample yake, wakampeleka mahali sijui inaitwa Chandaria, na haikuwa imetoka hiyo results. Hadi wale bado hiyo results yake haijatoka. Wakati tulimpeleka huko wakasema hawezi wakamtibu kwa sababu hajui ni shida gani. Sasa alikuwa anapewa tu painkillers na kuwekewa maji.
The search was long and arduous. The family printed Chesang's photos and distributed them, made Facebook posts besides viewing unidentified bodies as far as in Eldama Ravine.
Tulienda mahali yote kabisa kutumia pesa kukimbia mahali yote. Mtu akisema tumeona, lakini tukupata.
After 1 week of the painful search with little success, they made a phone call for the umpteenth time to request access to CCTV footage, hoping for a breakthrough. Unlike many times before, the hospital security management obliged.
Kufika huko ofisi yake, akaongea, akasema sijui mtu aliendaje nini. Atu CCTV alionyesha sisi alienda njia ya karibu moja hapo. Akakuja kuonyesha sisi mlango yote alipita mpaka tukapita karibu moja hapo chini. Na yeye anatangulia mbele.
Once the search party led by the hospital security manager crossed the hospital fence, Chepkwony recalls the security manager stopping to use his phone as they proceeded. A few meters ahead, they would discover the body of their kin.
Huyu mtu akaretrita karuti nyuma na akachifanya anaangalia simu yake. Sasa wakati alijifanya anaangalia simu yake, si tukasonga mbele. Charles akawa nyuma yetu. Alafu sisi na Mark tukaenda mbele. Kupika mbele akasema huyu Mark akaniuliza, si kuna kitu nyeusi hapa mbele ambaye ni somehow 40 or 50 meters away from the boundary. Sasa tukaangalia hivi tukasema ni mtu ama ni nini? Tukaenda tukaribia huko sasa tukaona ni mtu na hakuna mguu wala ana mkono. Hawa sasa wakakuja nyuma yetu. Tukaangalia kweli ni yeye. Hapo sasa huyu jamaa akasema wacha nitane mtu ya mojari. Tukaambia hapana. Na watu wa scene of crime ndio wanataka wajue ndio ijulikane ya kwamba amepatikana.
According to the family, the body appeared to be too well preserved for someone who had been missing for over a week.
Hata hii mangua iko kando, hakuna tamu. Na hii mwili tukaona ni kama kuna mahali ilikuwa amefichia kwa vile. Hakuna inchi hata moja. Kama angekuwa mtu ameosa hapo, si angekuwa hata mainchi anakuwa mingi. Tukuona tu hapo ni kama kitu aliletwe tu siku hiyo.
Mahali tulipata huyu mtu, tulipata yeye akiwa chini. Akiwa chini amefutwa mita moja. Kuna hapo hakuna commotions, lakini amefutwa futu moja ambaye imetoa nyasi kwa mahali chini. Hapo sasa inaonekana imefutwa kidogo hivi. From there, kuanzia hapo sasa tunaenda mbele kidogo. Kuna some fresh stones of blood. Fresh. Na hali ana inzi. Hakuna inzi yenye inatembea hapo. Tukiangalia huyu mtu ni kama mtu ametolewa mojari na ilikuwa ni the same night.
The family proceeded to bury Chesang, but 2 months since his death, there has been no news of what led to his demise. How did a sickly person who could barely walk get out of hospital, evading all the security officers, only to be found dead 1 week later?
Ni nini ilimpeleka Albert kutoka hospitalini mpaka kule alikufia? Hiyo ndio tunataka kujua kama familia. Kwa sababu huyu mtu alikuwa kwa mikono ya hospitali. Halafu ikakuaje anapatikana amekufa, amekatwa. Hiyo ndio tunataka kujua kama familia.
Chesang's family is not the only one mourning the unexplained death of their kin in hospital. There are several other incidences of suspicious deaths inside hospitals in Kenya. These incidences have exposed the extent of the lapse in hospital security across the country. With each passing year, a rising number of insecurity incidents have been reported in private and public hospitals across Kenya, ranging from minor security breaches to serious fatal events. National referral facilities such as Kenyatta National Hospital and the Moi Teaching and Referral Hospital have encountered the worst cases owing to their size and the large population of patients seeking medical services at the facilities. But insecurity in hospitals is not new. In July 1965, Rebecca Kimeu and her husband Kimundi walked into Nairobi's Pumwani Maternity Hospital, where Rebecca delivered a healthy baby. Sadly, after delivery, the couple was told that the baby had died, but upon asking to view its body, they were told it was missing. This incident would go down as the first ever publicly documented case of baby theft at Pumwani Maternity Hospitals, a recurring scandal in which parents lose their children and others get swabbed in secret, with more than a dozen cases of baby theft documented in the hospital over the years. Mama Lucy Kibaki Hospital has also been embroiled in similar cases of child trafficking and infant theft, with social workers at the facility nabbed in 2023 while stealing newborn babies and selling to clients for a sum of between 100,000 and 300,000 Kenya shillings. And in what would be the biggest rout in Kenya's medical history, 75 patients escaped from a male ward at Mathare Mental Hospital in 2013. Of the 75 escapees, 7 were returned by their relatives. 2 came back on their own, but the rest were never found. Also never found was a group of 10 bandits armed with AK-47 rifles who raided Iten County Referral Hospital to rescue their fellow bandits. A similar incident had occurred in August 2018, whereby an inmate at Kamiti Maximum Security Prison, William Wiruri Meta, escaped mysteriously from Kenyatta National Hospital despite being under police watch in chains and handcuffs. The most unsettling security breaches are where lives are lost in what should be a safe space for healing and recuperation. One such harrowing death was in 2015 of Cosmas Mutunga, a 42-year-old father of 4 and cancer patient who was stabbed 42 times and bludgeoned to death by a man and a woman while admitted in Kenyatta National Hospital, Ward 8C, for chemotherapy. The only witness, a 12-year-old boy, later disappeared under mysterious circumstances. Despite increased security measures, hospitals still remain a target of criminals out to steal equipment, supplies, and in some instances, bodies from morgues. In all, referral hospitals seem to have borne the biggest brunt of insecurity. This year alone, 6 insecurity incidences have been reported in hospitals across Kenya, including 3 deaths. They started in January with the death of Albert Chesang, a cancer patient who had been admitted to the Moi Teaching and Referral Hospital but disappeared from the ward he was admitted in, only for his body to be later discovered in a bushy area near River Sosiani. The most harrowing recent death yet was that of Gilbert Kinyo, a 39-year-old patient admitted at Kenyatta National Hospital for treatment of a neurological disorder, who was found dead in his bed inside Ward 7B after his throat was slit. Police are yet to establish the perpetrator of the crime. Iten County Referral Hospital, the biggest hospital in Elgeyo Marakwet County, was 2 years ago a scene of crime when armed bandits gained access to the hospital to rescue one of their own. Mark Kipsang, a clinical officer, arrived at the hospital the morning after the incident.
Okay, the story I had is that there was 2 or 3 gentlemen who came. They pretended as people who are coming to visit one of the sick persons here. And when they gained entrance, they now showed off on what they had. They were armed, actually, guns. I don't know, was it the G3 or AK-47? And the moment they wanted to take to rescue one of their own, I heard that the nurse was very busy on the other hand. But upon showing off the gun and alerting the other patients, I heard that the patients, even the sick patients, also feared for their life. You can imagine you are sick you are on fluids, but you have to take guard below the bed. That is the situation. Most patients took guard actually below the beds.
Lawrence Kogos, the medical superintendent at the referral hospital, said that they have since improved the security measures, making it safer for both workers and patients.
So the measures that we have taken are diverse. We have infrastructural measures where we have a fully functional CCTV system, or complete with a control room, where we're able to monitor all sections of the hospital and are able to identify any security threats, any security gaps before they happen. We also have the personnel. We have a contracted security company who have been given proper instructions on how to do their patrols, how to control patient flow, how to control flow of people from outside. And they get frequent training from their company and proper supervision. We also have, we've improved on our fencing. If you go to the mother and baby down there, we have a fence made of iron sheets and generally fencing around the hospital. This has also prevented, apart from people from coming inside, it has helped us control patients living through areas that are not the designated areas of living, which was a big problem in the past.
But according to Benson Biwott, a nurse at the Iten County Referral Hospital and Elgeyo Marakwet Branch Secretary for the Kenya National Union of Nurses, more needs to be done.
They should employ more nurses and more healthcare workers. Two, they should also be able to provide other security teams, like we should be engage also civilian police officers to be around and within, and update the CCTV cameras. They should have people who man the CCTV cameras 24/7.
Nelius Njuguna, a lawyer and program advisor at the Kenya Human Rights Commission, who was advocating for justice for the late Kinyo's family, said the patients have a right to be protected by the hospitals when they are in the facilities.
The responsibility to ensure the safety of Gilbert Kenywa was on the hospital. This is because the patient was admitted under the care of Kenyatta National Hospital, and therefore they owed Gilbert the duty of care. They owed him a duty to protect him and to prevent any incidents like this, because once you are admitted, your presumption is that you are under the care of the hospital. There's no one time you'll be thinking that there are outside sources or someone who will come to harm you when you are under someone's care. Your presumption is that they have put in measures to protect you and to ensure the security and safety of all persons within the facility.
In order for hospitals to do this, Dr. Kennedy Olwoch, a strategic security expert, said that there is need for them to take the security function seriously, something he believes does not happen now.
I'm sorry to say now the strategy is that looking across the nature of operations of most organizations, we are still clinging to the second industrial revolution kind of management structure. So the role of security needs to be elevated from down their organizational structure. Security should be a function of the executive. And anybody who is managing security should actually belong to the C-suite as far as I'm concerned. With the elevation of security function to the right place, that will now give the head of security the capability to decide the overall security architecture of the institution. And that one includes technology, that one includes personnel. A security is something to be designed, just like the way you're designing a house. So it takes somebody with the right capability, with the right authority to do that.
Major retired Peter Kala, another security expert, described the minimum standards that a hospital should have for security.
We are protecting three things in the hospital. We are protecting people, they are the workers and the patients. We are protecting property and also protecting information. Therefore, a basic standard measure within the hospital should be able to protect those three areas. So I'll start with the basic, and this is majorly the physical security parts, where now we must have, of course, now a guarding force, which is in place for the physical checks and all that. And then secondly is what I will call an integrated security system, So here we have integrated electronic system. Here we have an integrated access control in terms of people, vehicles, and who is getting who.
A good access control system, according to Major Retired Kala, should have 3 layers for it to be seamless and efficient.
At the access control, we must have layers. We must have the outer layer. Okay, these are just the basics now. We must have the outer layer, the middle layer, and now the inner layer. I'll start with the outer area. So we are talking about the perimeter wall in this case. So the hospital should have a proper perimeter wall with the proper standard heights, preferably 2.4 meters and above. And then above it, you need to have an electric fence which is functional. That's now the outer security. Now the middle layer is where we have now the access control itself. Here we have the physical guard. We also have the walk-in and walk-out metal detectors. We have contraband checks at this specific point. And now this is the middle area. We should be there, to counter what was not countered at the outer layer. So here we are doing the actual access control now. Who is going where, to do what? What are the restricted areas, which are the unrestricted areas? So then from there now, the inner layer now, if you are supposed to go to the X-ray department, for example, you should not go to the maternity wing, all right? If you're supposed to go to the wards, you should just go to the ward and not to another place. So this inner layer now creates the last form of barrier to ensure people go to the areas they are allowed. And these are all called the restricted areas. But you'll find that now, we try something the middle layer with access control, but now at the last layer, people are able then to access another area within the hospital, and this is where the problem begins.
Additionally, Major Retired Kala said that the security measures, including the physical infrastructure of the hospital, should be enough to discourage an intruder.
So hospital should exhibit the 4 Ds of security, the first D being deter. So, but the policy itself should speak for itself in terms of deterrence. By looking at it, any potential advancer should say, no, I'm not going there. Then number 2 is detection. We should be able now to detect this adversary as he moves across the layers. So we must have detection measures in place. We have things like sensors, whether the exterior or interior sensors, and they should be able to trigger some form of alarm once this detection is done, and some level of response. And then now from detection we go to delay. The advisor should not just walk all the way to his target. So we must have delay measures. This was what we're talking about, the access control measures within the various layers of security. And then the last one is deny. This is the overall objective. We don't want the adversary to get there to conduct the attack. So all these deter, detect, delay measures are made to deny the adversary from reaching his objective.
The challenge to provide proper security in hospitals also lies in the inability of hospitals to budget for the security function, but also in the security personnel's poor skills. Major Retired Kala finds that hospitals would want to retain a security company that bids the lowest in the tendering process and therefore compromise on quality.
Because if security company does not have trained guards, they don't have an alarm response for themselves. They don't have a backup system. They don't have a proper integrated security system in place that can guarantee safety and security for personnel within an hospital, then that's not a security firm that should be awarded to guard an hospital.
Dr. Olwoj believes that the issue of the lack of capacity is widespread within the security sector in Kenya for guards and security officers.
For example, when it comes to training of guards, I've been security guards, people who are at the lowest level. And you find that 3 important government agencies cannot sit down to agree on a curriculum for training guards. One agency insists on its own curriculum, another one insists on its own curriculum, another one on its own curriculum, and they are so much unready to an extent of even exchanging very unfriendly communications over the media instead of sitting down on a very simple issue. If we can't address guards training, when will we address managerial training? When will we address technical training? Because security is quite wide in the deep area.
If this is addressed, Dr. Olwoch believes that it will change hospital security for the better. For now, Chesang's family is yet to get closure, and with the government's failure, Chepkemoi's only hope is that God will avenge her brother's death.
Kenye mimi nilifikiria, nilimwambia tu Mungu mwenye alimfanyia tu hali hii kitendo, Mungu asilale, amuone na afanye jambo. Hiyo ndio nilimwambia Mungu, kwa sababu Mungu anaona, sisi hatukuona, hakuna mtu alimuona akifanywa hivyo, lakini Mungu aliye mbinguni aliona na anajua ni nani, na ninaamini hata mwenye alifanyia hivyo iko siku atajitokeza.
While hospitals like Iten County Referral Hospital, Kenyatta National Hospital, and Moi Teaching and Referral Hospital, among others, have improved on their hospital security, a systemic overhaul of the entire private security sector in the country may be long overdue if patient security is to be assured. For starters, a harmonization of the curriculum for security practitioners and an enforcement of policies and regulations would go a long way in ensuring security. Anthony Langat for Willow Health Media.
Meet Jane, a teenage girl with nothing but a birth certificate and a growing baby bump. She is in desperate need of healthcare. She has no ID, no insurance, and no one to turn to. Until now.
To bring you this story, I went undercover for 3 reasons. First, to help a vulnerable girl in need. Second, to check the realities of how a pregnant teenage girl in Kenya can get access to healthcare. And third, to put the social health authority system to test and see how it helps the people who need it the most.
This is our pregnant teenage girl. We shall call her Jane. She's 17, pregnant, and alone. Her eyes carry the weight of a future that should fall on a teenager's shoulders. She tells me that the baby's father wants nothing to do with her or the child. We begin at Wumwani, a place of hope. But first, a hurdle. We were turned back to Njiru Health Center for a referral letter because this is where she has been attending her clinics. Another door, another denial. At Njiru, bureaucracy meets desperation.
Hi, tulikuwa tunauliza process ya kuregister mtu SHA. First, she's an underage, hana ID, hana wazazi. How does she?
We were then sent to Mama Lucy Hospital to see if there was a way to get the teenage girl registered. It is here at Mama Lucy that a thread of hope appears.
Tulikuwa tunataka kuregister SHA, but the person we are registering she's here, she's underage and she's pregnant. So we were told tukikuja hapa mtatusaidia kumregister na hana wazazi. She's 17.
Tutafanya hivi. Nataka mtafute documents mfano wa hiyo office.
Okay. Document gani?
Tunataka birth certificate ya
iko akona.
Tafutua office nyingine si hapa.
Okay.
Ni mtugwa wetu sasa.
No problem.
Alafu mwende mtafute barua ya shule. Unaweza manage kupata ama aliwaza.
Alifika form 2.
Sasa ni sawa hiyo part. Umesema ni offer. Mko birth certificate za wazazi. Unaweza manage kupata.
Birth certificate original
copy. Kama unaweza manage kupata, utaenda kwa ofisi ya Buruburu kuona branch manager wetu. Hiyo case, hatuna vile kumtengenezea kitu kinaitwa temporary ID.
Okay.
Birth certificate
yake.
The certificate za wazazi zinaweza patikana.
Hizo tu. Original.
Ukienda hapo mtu atasikiza kesi yenu. Atima vile kuwasaidia na kutengeneza temporary ID ama hata na reason yake.
Na tatuambia
na akiregister itamsaidia.
Na tukakosa hiyo death certificate. Na birth.
At SHA offices in Buruburu, we managed to get our teenage mom successfully registered. We were assured that she and her newborn child could now get access to healthcare services for free until she attains the age of 18.
For teenage mothers, previously, teenage mothers will be identified either using the teenagers' mother's ID or the guardian, whoever has taken the teenager to the hospital to deliver. This brought some complications in our counting because if the mother is of childbearing age, it will so happen that if the mother delivers in the same year, our records would easily show like one mother had 2 deliveries in the same year. So to correct that, teenage mothers are now being identified uniquely. Our system has been configured to provide for a unique number, a unique identifier. So a teenage mother will visit our hospitals for delivery or even before delivery. In fact, they are better guided if they go to the hospital well in advance. The moment you confirm that you have conceived, then you go to hospital. So you will be identified uniquely using a unique number in the system. You will be taken through means testing. And as I said, if you are not in a position to pay, then you will be enrolled into the same program where you will now be paid for by the government. So you will be able to enjoy the benefits that come before, during, and after delivery. And now, even to make it much better, we are going ahead also and providing for adding the new baby to the teenage mother's profile so that it becomes a household, so that the teenage mother can benefit and the newborn can also benefit. These registrations are available in our level 4, level 5 government hospitals.
Refugees, orphans, street children, and inmates. A broken system stitched together, one registration at a time.
We also have now people in lawful custody. The law provides that the ministry responsible will be able to identify them. Then Treasury will provide budgets. So the people in lawful custody, the prisoners, their premiums are paid for by the government through an allocation by the Treasury, but it will come through the Ministry for Correctional Services, so that even them, when they require services, they will get them. By being registered, they are eligible for primary health and emergency. But by paying the premiums, then they are able to get the additional benefits. I wish to add that delivery is available both at the primary level and at the chief level. So if you are registered and you are a teenage mother or any other mother who requires delivery service, you can access them under primary health and under chief. So they are available. So we also have the other category of refugees. We work very closely with the department that is responsible for refugees, the Commissioner for Refugees, for purposes of identifying them, having means testing done on them, and then they are paid for. We have sponsor groups that come in also to help in paying premiums for these groups.
The invisible made visible, the voiceless heard. But just how does the system capture this?
We'll walk you through a simple step-by-step guide on how to register for SHA under the Special Persons Group. Please remember, this registration can only be done at Level 4 or Level 5 hospitals. In this example, we'll show you how to get a teenage pregnant mom registered. Once a teenage mother presents at your facility, open the SHA Assistant Registration app. Select Underage Mother under Social Group categories. These mothers do not have national IDs yet. Choose Temporary ID as the identification type, and the system will automatically generate a unique ID. Enter the first name, either from the birth certificate or provided by the next of kin. Click Save. On the next page, fill in the biodata. This includes the last name, county and sub-county, ward, title, gender, date of birth, civil status, and place of birth. Add the next of kin's phone number and email. Confirm all the details, then click Save and Submit. Once submitted, the mother's card is instantly activated. It is valid for 1 year, covering both the mother and the baby. Jane was lucky. But how many gave up before they find the right door? The real test for SHA isn't just the policy, it's in the process. In every Jane who dares to hope. For Willow Special Reports, my name is Yvonne Kawira.
You'd be forgiven to think that what you're looking at is a condemned building or one under renovation. No. What you're looking at is the current state of the patients' washrooms in a ward at the Kenyatta National Hospital, Kenya's biggest Level 6 and the biggest referral hospital in East and Central Africa. This ward houses pregnant women and those who have just delivered. You can imagine my horror at the thought of a mother from a cesarean section or normal delivery who needs to use a washroom. And this is what they come into. These same mothers will wade their way through the flooded floors, navigate how to help themselves, either in this kind of toilet or in this one. Wait for it. That has used sanitary towels disposed at the back. After weaving their way here, they will go to their newborns whose immunity is still trying to figure out what germs are. These same washrooms are shared by expectant mothers who, because of high-risk pregnancies and other complications beyond them, have been admitted awaiting delivery or stabilization. And this is just one of the wards and the maternity unit. We went ahead to look at the hospital's most recent and publicly available audited financial accounts. First, the Auditor General gave them a qualified opinion, meaning the auditor identified specific issues with the financial statements. From the accounts, Kenyatta's total revenue for the year ended 30th June 2023 was 20 billion shillings. Reproductive health services fees had contributed 408 million shillings in revenue for the same year, and there were no costs reported in this line. Expenses on repairs and maintenance was 447 million shillings. 156 million of this was in buildings, and here we made the assumption that the washrooms fall under this expense line. In its administrative expenses, KNH spent 86 million shillings in cleaning services, an amount that had doubled from the previous year which was at 41 million shillings. In the financial year ended 2021, the repairs and maintenance costs were 296 million shillings, attributed to minimal repairs undertaken for plant and machinery during the period. This amount, however, increased to 441 million shillings in 2022. From its website, Kenyatta National Hospital has 50 wards, 22 outpatient clinics, 24 theatres, 16 of which are specialized, and an accident and emergency department. It has over 6,000 staff. Out of the total bed capacity of 1,800, 209 beds are for the private wing. In the financial year 2022-2023, the hospital had a bed occupancy of 97.8%. The hospital was almost at maximum capacity. The video we received was just from one ward, and we do not know the state of the washrooms in the other wards, neither do we know the state of the staff washrooms. The health implications of dirty hospital washrooms can be life-threatening, from hospital-acquired infections, some of which are resistant to available antibiotics, urinary tract infections, gastrointestinal and diarrheal diseases, respiratory infections, skin infections, vector-borne diseases, and obviously mental health issues from anxiety and stress of having to use such facilities. We reached out to the Kenyatta National Hospital management for comment, but were yet to receive any feedback at the time of airing this video. Dr. Mercy Korir for Willow Stories. Willow Lifeline Dialogues is hitting the road again, and this time we're at Eldoret. We're creating space for honest, open conversations about the Social Health Authority SHA and what it really means for our communities. Whether you're a health worker, caregiver, or an ordinary Kenyan trying to understand how SHA will affect you and your family, this town hall is for you. With a focus on transparency, inclusion, and collective problem solving, we invite you to come and share your thoughts, ask questions, and be part of a dialogue that puts people first. Together, let's talk SHA. Let's shape the future of healthcare delivery in your region. Good evening, Kenya, and a warm welcome from the City of Champions, Eldoret, in Uasin Gishu County. This evening, we come to you live from a region that has produced world-class athletes and now stands at the tracks of yet another national race, the race for equitable healthcare. Since the launch of the Social Health Authority, SHA, in October of 2024, from the rolling hills in Nandi to the boiling geysers of Bogoria, from Kapseret to Langas, from Kapenguria to Iten, the questions remain.
Is SHA living up to its promise, the promise of rethinking healthcare for 55 million Kenyans? Here in North Rift, and a town that straddles rural and urban realities, the stakes are high. Public hospitals are overstretched. Private care is perceived to be costly, and many residents, especially in remote villages, are still unsure of how to register for SHA, what is covered, and where to seek for help when they need it the most. And yet, the potential is enormous. SHA could be the game changer that Kenya has long needed if it listens, learns, and adapts. That's why we are here this evening, to strip away the jargon and hear from the people, you, to ask the hard questions, hold systems accountable, and most importantly, spotlight the voices that matter the most, your voices. And joining us on the panel today are thought leaders, frontline professionals, and policy drivers, each bringing unique insights from the healthcare trenches to the policy table. And on our panel is Valentine Morogo. Valentine is the SHA Regional Manager in North Rift. She has over 15 years of leadership in finance and public health. She is helping to chart the course towards universal healthcare coverage. Karibu sana, Valentine. Next to Valentine is Dr. Ruben Korir, who's the medical superintendent at Mama Rachel Ruto Maternity Hospital. He's a pharmacist with extensive leadership experience in the healthcare space within Uasin Gishu County and in Kenya. Next to Stephen is Sharon Kandie-Sang, who's the founder and CEO of Rapha Hospital and Clinics. From one small clinic to 100-bed multi-specialty hospital, Sharon's journey redefines what accessible private healthcare in Kenya can look like. Last but not least is Stephen Koech, who's the chairman of the Uasin Gishu Community Health Promoters and has been a community health worker since 1997, being in the space of polio, malaria, HIV, and TB. These are the people at the front line of change. And tonight, this is your platform. My name is Dr. Mercy Korir, the CEO and Editor-in-Chief of Willow Health Media, and I'll be your moderator as we navigate the conversation of SHA within North Rift region. Welcome to Willow Lifeline Dialogues, the Eldoret edition. Be sure to join us live on our YouTube pages and on our Facebook page, because we want you to be part of this conversation. You can join the conversation online, and our hashtag is Let's Talk SHA. We want to get to the heart of this conversation. We want to talk about the matters that matter to us, which is healthcare. On our sign language is Mini Mbesa, and will be assisted by Meresha Owiti. We strive as much as possible to make sure that we accommodate and we are as inclusive as possible when we are having conversations around healthcare. And without much further ado, we'll get straight into the conversation, and we'll start from our host, Uasin Gishu County, from Dr. Ruben Korir, who's the medical superintendent at Mama Rachel Hospital. And we just want to hear from you, Daktari, from the early feedback and data in the implementation of SHA, how has it been effective in responding to the needs of residents in Uasin Gishu County, and specifically at Mama Rachel Ruto Maternity Hospital? Please pick your, yes.
Thank you so much for that question. Thank you, audience, for being here with us, participating in how management of your health is concerned. Thank you, panelists, as well, for being here with us. So to your question, SHA, as you know, has been here for close to a year now, and I'm sure Dr. or Madam Valentine will be able to speak to that. And just like any system that is introduced, there is obstacles, there are teething problems. But fortunately, with the support of our leadership in the county, with the support of this able team that is before us, the CHMT, County Health Management Team, as well as the community that we serve, we've been able to embrace this new system And we've been able to encourage as many as possible in the public to be able to register. I am fortunate to lead a facility where we encourage every single member that receives treatment with us to be able to enroll for SHA. That encourages those who are less fortunate in the society, who we are trying to reach, to be able to access healthcare. And we're fortunate to do the same in various of our facilities across the county, within the CBD as well as the outskirts. I believe every single facility is registering the members of the public to SHA. SHA, as you know, is free to register, but there's premium payments, as I'm sure I'll leave Madam to speak to. So I think what we can say is the idea behind the health system is to improve health outcomes. If people are able to access healthcare, then the health outcomes are achieved. Health outcomes such as reduced diseases, reduced death, increased access to skilled deliveries, increased access to equipment. And this is the idea behind SHA, to be able to encourage the public to register to a system that will promote or encourage them to seek this healthcare or better healthcare outcomes. So I think that's what we can be able to say as a county. We're encouraging the members of the public to register for SHA, and by virtue of registering, they're able to improve their health outcomes in their lives. Thank you.
Thank you, Dr. Let's hear from the private sector. Sharon, from Rafa Hospital, what has been the experience since the rollout of SHA? Is it living up to the promise?
Okay, thank you, Mercy. I think for us, the first thing that we like about SHA is the fact that all facilities, there's standardization in the contracts. So even if you go to a level 4, level 5, most of the services that were limited to the high levels of care, you're able to get. So if the facility, let's say it's able to do total hip replacement, if you're a level 4, you're able to get that treatment and go home. Versus before, you would be transferred to a level 5, level 6 facility to get that care. The other thing is the emergency care and the ICU packages. So we've seen for our patients, it's better. So what I can say is SHA is offering better packages than what NHIF was doing before. For my patients who are dialysis patients, it's better care for them, because there are catheters that were not covered before, they are covered now. The patients are able to get fistulas, they're able to get their drugs for chronic illness. So overall, for us, for the patients, we feel like it's a better package for them.
Okay. Thank you for that feedback, and we'll be able to hear from the community and some of the patients if that has actually been happening. Let's hear from Stephen, representing the community health promoters, on whether SHA has lived up to the promise. What is the feedback since the rollout from the community and from the community health promoters?
Thank you very much. I hope what we have done so far, we as the agents of SHA, we have done a lot. We have registered, and we have been doing a follow-up for the people that we have referred them to our facilities. And we have adequate time, and we see that SHA is working, and it is very good. And we urge each and every one of us to join SHA. But only the problem that we are facing in, we have registered many, but they have not yet paid their dues because of maybe financial problems and whatsoever. Otherwise, we have achieved very much in the ground, and I hope so far so good. Wasingishu, we have done the best. After His Excellency the President has given us that opportunity, we as community health promoters, we really appreciate very much and thank him, because I was not supposed to be here today, and I'm here because of His Excellency the President, because he appoints community health promoters to be our health sectors at the ground level. So we are very privileged also to join part of you.
Okay.
Thank you.
Thank you, Stephen. And we go to Valentine, the North Rift manager for SHA. How has the experience been in terms of the uptake and registration of SHA and the teething issues that had been experienced initially? What is the progress up to now?
Thank you very much, Madam Mercy.
Daktari, and thank you everyone for coming to be together as we discuss matters health. As you've said, I'm Valentine Morogo. I cover North Rift as the regional manager in charge of SHA, and I appreciate for this opportunity. And the far we are, yes, SHA came into existence in 2023, October. We all remember, to replace NHIF. And since then, we are almost 7 months old, and I think we are progressing. I'm happy to have heard from our service providers, and I'll also be happy to hear from the users, because at the end of the day, it is the beneficiary who will tell us whether it is serving the purpose or not. So the progress so far, I'll say that we started on registration, basically, because that is the first point of interaction with SHA, where you register as a member. So since October to date, we've overall in Kenya registered up to over 18 million members. And in Uasin Gishu, we are at 1.4 million members out of 5 million in terms of population. So I'll say we are at 27%. So I'll say that it started very slowly, but later on it's peaking, because even in our offices, we realize that there are so many inquiries, many people coming to register. So on signs that it's working is, Daktari is, as my colleagues have said here, yes, it has challenges, and we appreciate the challenges. And where I sit is, when it started, the challenges outweighed the benefits. But as we speak now, I can confidently confirm that the benefits outweighs the challenges. One is that we are aware that when you register, you use the cover immediately. And that, I believe we can confirm that. Number two is that the wide range of coverage in all HCPs. There's no HCP that was left behind, as long as they are registered, licensed by the KMPDC. And the process of contracting is a bit seamless, or is seamless, because it involves e-contracting, where you don't have to send your contract to head office, then comes back, that bureaucracy of the delays. We also have the ability to access care at the primary care networks without, even for those who have just registered, you can access care even before you pay for your premiums, which is a plus to Kenyans. And I've seen that work. I've seen that work, and it can be confirmed from even the users themselves. So just to mention a few, those are what I can say. Thank you.
Okay. And they have been the key successes that SHA has been able to do that were a challenge under NHIF, that you as facilities and as a county are seeing the benefits of?
Okay, thank you for that question. Like I had mentioned before, every new system has its teething problems. NHIF, we had it for several years. I think it was over 15 years, NHIF. SHA has only begun, as Madam has said, for seven months. And so it's expected that there'll be challenges along the way, but what I can speak to is the immense benefit that we ourselves, as Mama Rachel Ruto Hospital, which I superintend, has benefited from. We are the first county maternity hospital in Uasin Gishu. This is MTRH, is a national referral hospital, so I'm not counting it as such. And so the benefits that we ourselves are getting, we have a newborn unit in the Mama Rachel Maternity Hospital. And that we could not say we could benefit from prior with NHIF, seeing that we were the first county maternity hospital. So I can say we're benefiting from that. I can give you a real life example. We had twins born at Mama Rachel Ruto Maternity Hospital, but they were premature. And they had to be hosted at the NBU for some period of time until they arrived at the standard weight as well as the standard health levels that we could be able to discharge. We had them for 90 days, twins for 90 days. And SHA was able to pay for both of them at an amount of 3,000 per child per day. So that's 180 per child, 180,000 for the twins. And SHA was able to cover that at a premium of about 1,300 shillings per month that the mother had to pay to SHA. So that's just one example. We've had several others. All of them are successes. And so I can say, I do not want to disparage NHIF. NHIF was beneficial for us for the period that it was there. And we are grateful to His Excellency the President for introducing this new system in SHA. And we believe this new system in SHA is also going to benefit us going ahead. It is expected we'll have challenges as we proceed. For instance, what Madam has said about perhaps some people are unable to pay the premiums when it's required for the system to be active to benefit them. But these are things that we can be able to improve on going forward. So SHA is beneficial to us. It has helped on a personal level. I can speak to that as a manager, facility manager. And the dozens of and hundreds of people who've come through our facility have benefited from SHA. I encourage those of us who are sitting here to register. And I know it's going to benefit all of us as well.
Okay, thank you. Let's hear from Sharon. Has SHA enabled you to do any patient-centered improvements as a private provider?
Okay, thank you for that question, Mercy. I think for us at Rafa Hospital, because we are mostly known for chronic illness, patients who have issues with renal failure, with SHA and the chronic illness packages, it has enabled us to care, involve the multidisciplinary team, because you find that patients who you had recommended echoes or some specialized tests like hemoglobin A1C that you were not able to, the patient was unable to pay because the test is costly. You find that because of that chronic package and the enhanced packages for patients who suffer from those diseases, we're able to actually have clinics and have the patients see specialists. So the patients that would have had complications are able to be taken care of earlier than before. So we see that our patients are happier because they're able to get their medications covered under SHA. They're able to get the lab tests and the radiology test covered under SHA. The other thing that we are doing as a facility is because there's the integration that you can integrate your EMR system, the healthcare system, to SHA. So we are working on that, and we feel like it will improve how the patient information is passed through the system, or if the patient goes to another facility, that the information or the tests that have been done at our facility, if the next facility where the patient visits and the patient has integration to the SHA system, the doctors will be able to see the treatment record of that patient. So I see that with that, as a requirement that SHA is requiring for facilities to do, I feel it is very good for the patients. So you don't have to ask, I did a test, I don't know what the result is, because it's already in the system. So I feel that that is a plus for the patients. Thank you.
So, from our other two town halls and the stories we've done, some people raise the issue that when they go to a private facility, they are asked to pay over and above what SHA has settled. Is that the case in your facility or any of the private facilities within Uasin Gishu?
I think what they're referring to is mostly when it comes to outpatient. When you're looking at what SHA is covering for the outpatient packages for just normal cases, not the chronic. When a patient comes in and maybe it's something to do with just malaria or something like that, you find, because there's no clear guidelines on how the reimbursement would work, you find that the patients are asked to cover for the lab test and the medication because the reimbursement is not clear for that.
Okay. And I'll quickly just throw that to Valentine, because you clearly said once you have registered, you go to a facility that you don't need, you can access healthcare services. So how come then people are asked to pay extra?
Thank you, Daktari, for that question. As she said, it's an experience, and we work on capitation model where we pay a facility an amount per head, per quarter, and that's according to the population of that particular area. That is how our capitation model works. And when we pay to the facility, we pay for everyone for that particular region. For example, if it's Uasin Gishu County, we have a population of almost 1.1 million. We pay an amount of 900 per head to that as capitation times the number of population. Then that amount is subdivided to the respective facilities in that particular region, basing on the population in that particular area. So what happens, Daktari, is that apart from a few exclusions, that amount should be sufficient, apart from a few exclusions which are there, which will be taken care of under inpatient. So maybe, as Daktari says, or Rafa says, maybe those clarifications is maybe what they want to get from us, if at all it's not clear. But from where we sit, it should be walk in, walk out, except for a few exclusions which are there.
And is that the case, say, in a public facility? Can they walk in, walk out without a need to ask, without a need to pay out of pocket? Because the whole idea of SHA and prepaying for healthcare is that if I go to a facility, then I don't have to pay at that point for care. Is that the case in our public facilities?
Yeah, actually that is the case. As she has mentioned, we have quite an elaborate spectrum of what SHA can cover, including outpatient, meaning anybody who wants to come in and receive treatment can simply do so if they're registered with SHA. Similarly, and we're talking about X-ray, ultrasound, we're talking about simply attending a clinic for consultation and so on. All that is covered by SHA. So I can attest to that as Mama Rachel Ruto, where we receive patients who just walk in, present their membership. There's obviously a form that needs to be filled for claiming purposes, but thereafter they receive whatever treatment it is that they require. Let me just add that initially, as SHA was being rolled out, and we're beginning to come to terms with how it works, there was problems with the whole referral structure, whereas patients had to first go through primary care. She mentioned PCN, primary care network system, whereas a dispensary, for example, or a health center, before they can be able to access higher levels of care. Whereas now, I don't know about other counties, but in Uasin Gishu County, they're able to come directly to Mama Rachel, for instance, and they're able to get that care at outpatient, at mother-baby, at antenatal care, postnatal care, which is the child welfare clinics. All these are able to be accessed at Mama Rachel and other higher level facilities as well, before, or rather, without requiring the patient to have first gone through dispensaries and so on. So I can say that is a plus for our patients. Before we had to send them back to where to the nearest level facility to get that care, and then be referred officially to us, but that is no longer the case. So I think that I must commend SHA for streamlining that. And so I think it's an ongoing, like they say, it's a growing concern. We continue to improve as we go along.
Okay, let's hear from Stephen and from the community. You've heard from the private sector, from public, from SHA. Is that the same feedback coming from the community, from the households you visit, and from the community health promoters, that people can walk in, walk out, especially at the public facilities, without a need to pay at the point of seeking services?
Thank you for that question. I would like to only clarify one, because we had a client who he had a problem and we had sent him. We refer him he went to private hospital, which is Life Care, and he had a problem in abdominal pains, and there was, when he was there was a form that was filled for SHA, and they were waiting the requisition from the SHA headquarters. And while after around 2 days, because so many medication was done, and eventually that man was assisted, and SHA definitely pay everything for him. After the day they were released, In fact, it was me who came and took him home, but he was assisted, he didn't pay anything, and I found it SHA is very good, and he's working even in private sectors. That is an achievement for our people. And if we go to our public hospitals and whatever, there is no payment at all, because once you have referred them, they go there, they come back with the good results that we didn't pay anything, because SHA covers everything. And that is, we see it is a progress for our community. It's only that when paying this SHA, we request, some families they don't have enough proper money for which they can sustain these people. So we requested them to reduce the amount to 300. That SHA had already fixed that you will be paying for the poor people, families that are not unable to reduce, because right now you cannot assess or you can register somebody or family with 300, but minimum now is 500 and beyond, or 1,000 or whatever. So we are only requesting to reduce that amount for all people to chip in, because some families was not unable for that. Otherwise, it is good achievement and ongera kwa even public and private sectors. Thank you.
Thank you. Thanks for that positive feedback, because sometimes the feedback we get, is that SHA is not working. So it's good to hear from the community that there's some positive aspects to it. We want to take questions from the audience that is here live. So if you have any question or a comment you'd like to make, please raise your hand and we will direct you to where you'll be able to ask your question. Please raise your hand so that we're able to see you and we're able to give you that opportunity to ask your question. And also for those who are online, the hashtag is Let's Talk SHA. Pose your questions and your comments so that we're able to pick them up and we're able to ask the panelists. And if you have any comments for the panelists, you're able to direct them to the panelists. So as we get ready for the panel for the questions from the audiences, I'd like to ask Valentine. Stephen has talked about the 300, minimum payment, which when you do the means testing, I'm yet to find somebody whose was 300. Daktari there, when he's talking about the twins who are delivered, the mother paid 1,300. What feedback are you getting from Kenyans in regards to the premiums that they are supposed to pay? And if they're not able to pay the premiums, what happens?
Thank you, Daktari. On premiums, the approach is the means testing, which I believe all of us understand. When you register, there are questions that you are asked to determine how much you pay as premiums. So expectation from Kenyans was they'll pay 300. That was the main expectation when SHA came in. But the tool assesses your capability. That's why there's those many questions that are being asked to assess your level of payment in terms of premiums. Yes, we've experienced a situation where someone is very needy and the premiums maybe comes to 1,000 or 1,300 or even 2,000. So in such cases, the system is able to give an opportunity for appeal. And when they appeal, sometimes the premiums reduces, sometimes it doesn't. So because it is an AI, is automated where it is able to review it in itself. So, so about reviewing the premiums to 300, it's a concern and it is noted. And I believe as we progress, the government promised that it will be able to come through for those vulnerable community or population, which Daktari, I think it's work in progress. And I believe maybe in another short time that will be looked at, because under NHIF there is a group that was vulnerable and the government was sponsoring such groups. And I believe it will work with the community. It will be able to advise on those who will need sponsorship. But as at now, it's not there. Thank you.
So you say people are not able to be sponsored if they are unable to pay completely?
I think it's something that we will be able to guide as soon as we get the response. But where I sit, I know there are plans that will be considered, because according to SHA proposal from the at initial stages was those who will not be able to pay will be sponsored. And also there are well-wishers also. Like now in our Uasin Gishu County, we have MCAs who have come on board to request to sponsor vulnerable groups. And they have already identified those groups, and we are just going to register them, and the leaders will sponsor. So already it is happening with the local leaders. Thank you.
Okay, thanks for that, Valentine. And also colleagues from the Fourth Estate, if you have any questions, also do let us know. So we'll take the first question. Please tell us your full name and if you're representing any organization, and if it's a question directed to any of the panelists or a comment, please go ahead.
All right. My name is Ochola Francis. Few questions. So SHA was supposed to be a bridge in healthcare between the less fortunate and the affluent. But however, we find that, we still have different packages in terms of allocation, in terms of premiums. Especially, let me poke an eye to the politicians. For us, we have limited packages. Maybe you pay a premium of 1,300. When you go to the hospital, there are those services which are limited, or the amount is limited to a certain point. However, the politicians, you find they have tens of millions. Is there equity? Is there equality in the services we are providing? While we want to bridge it, yet we don't, because we still have categories. Those who get premiums, those who don't. Another question is, what are the parameters for premiums? I have interacted with a case in which same family, the father and the mother, they apply for SHA. One gets a premium of 700, one gets 1,500, using the same details. So they apply both of them so that they use the one with the low amount. Is the parameters constant for all the applicants? Yes, thank you.
Thank you very much, Ochola, for your questions. And Valentine will ask you to pick those questions on equity, if there's equity in the benefits that people take, and how come there's different premiums required from the family. So we'll take our second question, your full name, and who you are representing, if at all.
Okay, good evening.
Good evening.
I am Betty Rono, Community Health Promoter, Soy Sub-County. My question goes to Valentine. Disabilities. We are facing challenges when we are registering them, because you find that she's disabled completely, but she'll be given at a rate of 800 and 1,030 shillings. Elderly people, you can get a grandfather of 80 years, but he or she will be given at 1,030 shillings. What are we supposed to do? If we appeal, it should. It's not coming down from we were told it is 300. Now we are facing challenges. We are told CHPs, you are the ones that you are making our price to go up. So we are facing that challenge. Thank you.
Thank you, Betty. That's a critical question, and I can assure you we've received that question also from the other town halls that we've had. People are wondering, people with disability, what happens to them and who pays the premiums? Are they in the group of indigents? And Valentine will give you that question, and also maybe Dr. Rikorir and Sharon will give us what your experience is when these people are seeking healthcare services. So please go ahead, your name and your question or comment, if any.
Okay. My name is Ian Limo, and my question is directed to the regional manager for SHA. My first question is, we find that some of the procedures or services offered in private sector are more expensive than those offered in the public sector, even though the procedure is the same. So when it comes to reimbursement, do you reimburse based on the rates of a specific hospital in a private sector, or you reimburse the same amount for both the public and the private sector? My second question is on dependents. Under NHIF, a dependent did not have to get an NHIF card for them to access services. For example, we have people who are over 18 but are still depending on their parents, or we have spouses who depend on another spouse. So when it comes to SHA, a person who is over 18 and is still a dependent has to acquire SHA, yet their main source of income could be from their parents or something like that. So thank you.
Thank you, Limo, for your questions. And we'll get the last question from the audience before we go to online audiences. Please go ahead with your name and your question or comment.
Okay, thank you. My name is Bonventure Machuka. I'm a senior medical student at Moi University. And my first question goes to SHA. First of all, I think we need to understand, there has been stories of inequalities in benefiting from the remittance of the scheme. So how are you going to address that? How are you going to address that? Somebody can be able to get maybe 200,000 covered, but the other one maybe gets less amount. So the second question also, last week I was reading the newspaper, and there were reports that there is also limited awareness or lack of awareness about the scheme. How is SHA doing? What is SHA doing around that challenge? And then also the third question to SHA is payment for special groups. We have children's home, we have the vulnerable people who cannot be able to pay for this. So how do you get to cover those special groups? And then my other question is to the hospitals now. There's, of course, accessibility and affordability to quality healthcare. So SHA is trying to bridge that gap of affordability, and where SHA is providing cover for some services, sometimes you might find some medication or services are not there at the hospital. So what are you doing to bridge that gap between accessibility and affordability? The last one is to Willow's Health Media. Congratulations, and thank you for the good job of engaging the audience. My question is, how are you going to translate this knowledge once you find the findings from the audience, the findings from the public, and also the relevant stakeholders? Who are you going to engage, and how is this going to benefit the 55 million Kenyans? Thank you so much.
Thank you very much, Machuka, and also thank you for throwing a question my end. We'll get to answer. Let's start with the very important ones to Valentine on SHA, especially on the question on equity, benefits. Is it the same to everyone? I think you can tackle that, and the issue of premiums in the family, that two people in the same family are getting different premiums when they do the needs test.
Thank you, Dr. Thank you for those questions. I'll start with the equity, the one about equity. Mr. Ochola asked that there are different packages for, he talked about MPs and the normal mwananchi. When you look at SHA, when it came in place, all other schemes, we remember that initially we had quite a number of schemes under NHIF, but when SHA came in, according to SHA, it's supposed to be one scheme for all Kenyans. And as we speak, it is that one scheme, national scheme, where all Kenyans must contribute, those employed and those not employed. If you're employed, a 2.75% is deducted from your salary. If you're not employed, you do means testing, and an amount is apportioned and you pay. So that is the main health insurance that is there for all Kenyans. So when you mention about the MPs, I'll say that apart from the main cover which they have under national scheme, anyone is free to have any other arrangement to have an extra cover. So to answer Ochola is that if an MP today or a civil servant today walks into a hospital with only the SHA cover, which is deducted from his salary, the benefits are the same. He'll be able to access the same benefit as you do access. So maybe where the difference comes in is where one gets an extra cover, which as civil servants, there's an extra cover which I'll mention that through maybe their medical allowances as employees, they're able to have a fund separate to take care of their medical care. That is why you may notice it is different, but without which the cover is the same. Maybe if you need further clarification, we can still have a one-on-one to explain further. And on parameters of premiums, why do a spouse get a different amount and another spouse get a different amount? As I said, it is an automatic or an AI system where it computes premiums on its own, and it checks a lot of background information about that specific person. So even if one is your spouse, their background information may not be the same as your information. Yes, you may put, you live in a certain house, the same house, she also puts the same house. But other background checks, like maybe your mobile numbers may not be the same, other factors may not be the same. That's why you get different premiums. So you cannot expect same premiums for the same person. The system is able to compute individually. I want also to clarify that if you have a spouse and one of you is contributing, the other one is not required to contribute. You use the same household cover because that is a household. So if a husband is registered and is the contributor, then the spouse should just benefit. You don't have to pay. I hope that is clear. Thank you.
Okay. There was the issue from Betty Rono about people with disability, where they enjoy certain benefits from the Disabilities Act. Then here they're required to pay premiums and probably they don't even have a source of income. So what happens in such a situation?
Thank you, Betsy, for that question. It's a very valid concern because they are less fortunate in the community because of their ability. So as I said earlier, the government has plans to consider such category of people. And I believe soon that will be looked at, and I'm still taking it as feedback because we have many. We talked about even our brother, the university student Machuka, he asked about special groups. So that it is the same category, the old, the vulnerable, the poor, all those will be looked at. And as I said, there is a beginning already. There are counties who have started to sponsor such less fortunate in the society. And we have even one in place here in Uasin Gishu, an MCA who already does that. So I believe it will come and eventually all those people will be looked at, but I'll take it as feedback as well. Thank you.
Okay. Thank you. I'd like to hear from Dr. Korir, Sharon, and Stephen about your experiences based on the questions that have been asked, especially on paying premiums, the issues of reimbursements. We can start with you, Dr. Korir.
Right, thank you for that question, and thank you, audience, for interacting with us. On the matter of premiums, I think Madam Valentine has spoken to that. We have experienced that quite often in our facility, Mama Rachel Ruto Maternity Hospital, as I'm sure my colleagues have as well. We have various people claiming that they have filled in this assessment form online, and it has produced a figure that they are unable to manage to pay. Unfortunately, as a facility, we have no way to address that. The only thing that we can do is direct them then to SHA to be able to take it up with them. Now, where we suffer, let me use that word, as a facility is we cannot deny service to anybody. The unfortunate bit is we have already offered this service to the patient, and thereafter they are unable to pay because their SHA is not up to date, or they have not registered altogether, which is what one of the audience members, I believe it was, I think Ochola and Limo, spoke about the issue of dependence and so on. It's unfortunate that as a social health scheme, it's about the majority catering to the minority. Those who are able to now absorb the shock for those who are unable. That's how our social system works. And so SHA operates in the same manner. That is why Madam has mentioned that those who are employed are paying a lot more than those who are unemployed. So I think it is ultimately the desire of those who are managing SHA and the national government as well, that this system is going to benefit everybody. But until that point, we will have cases where the disabled, like Madam Betty spoke about, indigents, those who are completely socially, economically unable to handle the premiums. Eventually, they may be well-wishers, they may be members of parliament, or those who are able financially to be able to support this. But until then, services will continue to be offered. This is what I want to assure the members of the public, that you walk into any facility, at least as far as Mama Rachel Ruto Maternity Hospital is concerned, services will be offered. It is our desire, it is our appeal that as many people as possible register for SHA. And we hope that the premiums, as Madam has said, will be favorable to as many people, because the more people register, the better. Allow me, Daktari, to speak to what the student Bonventure mentioned about bridging the gap to accessibility and medication. What we're extremely grateful to SHA for is the relatively short period of time for reimbursement. We have benefited quite a lot as a facility, where the funds that we claim are paid to us within a relatively short period of time. What that enables us to do as a facility is we are able to then purchase commodities. We're able to purchase medication, we're able to purchase equipment that were up to that point we were unable to have. And so that thereby benefiting whoever it is that is coming to access health services from us. So it is our desire, ideally, not to have the patients purchase these medications outside the facility. But as the program continues to unfold and to roll out, and SHA continues to reimburse in a relatively short manner, which I believe might to then afford whatever it is that is lacking presently and be able to provide it in future.
Thank you, Dr. Korir. Sharon, on the same issues of reimbursement and people not being able to afford the premiums, what do you do in such a situation?
Okay, thank you, Mercy. I think for us, when the issue of accessibility and when patients come and let's say they have not registered for SHA, usually because it's an online portal, we try to assist the patients. And we've tried, like what the CHPs have said, you'll find that if the one spouse had tried and the prices was high and they could not afford, then we'll attempt to try with the second spouse. So we'll go with the lower number, and usually we encourage them, especially if they're going to do a surgical procedure, for it to get approved, we usually encourage them to try and raise about at least 60% of it. And then you find that if you pre-auth something, it goes through. And if it's a very needy case where they don't have money, we usually find well-wishers who are sometimes able to pay for that. If not, then we'll provide care and transfer them to the nearest public facility that they can get care. When it comes to reimbursement, for us it's a mixed bag. There are some services where you find, especially for chronic illness, they are paid better than for surgical cases. You find for surgical cases, for most facility and same for mine, reimbursement is very much behind. You find that even some cases that were done in October up to now have not been reimbursed. I think that's why one of the questions someone had asked about why, if the packages getting reimbursed from public and private are the same. I think the contracts are the same. So you find for private facilities, the difference you find from facility A and B is mostly based on the risk. Because if the payment from SHA is going to delay, you'll find the facilities will try to recoup majority of the cost of treatment from the patient. So you find other facilities asking the patients to pay more out of pocket versus what SHA is paying. And I think if SHA can work out that reimbursement, you'll find that most facilities will consider just taking whatever whatever SHA is paying rather than co-payment for patients. I think the main reason is for surgical cases, most facilities have not been paid. But for bed rebate, if a patient comes in for pneumonia, they get the medicine, and you find most facilities do not co-pay for that. It's just for the surgical cases that is making most facilities shy of just using SHA 100%.
I have a follow-up question on that, and I'll come to Valentine and Dr. Korir, specifically on that, asking patients to pay over and above what is in the tariffs. But I want to hear from Stephen first about the experiences as community health promoters, and Betty there really put it aptly, that you do the means testing, it's high, and then, it's the community members who think you are doing something to the system such that they are paying higher. What do you do in such instances?
In that cases, first of all, let me refer another question that for private sector. I want to request, because there is some hospital that we have around Wasingishu. We had a client who was in hospital. He was treated, eventually he died. While during that period, the family arranged for their burials, but the facility refused to hand over the burial permit. And SHA already has approved a certain amount for the payment. But they insist you have to pay the money for us to release for you burial permit. So that is the challenge that we receive, because one of our parents called me and asked me, we have been done for this and this, until he sent me the message from the reimbursement from SHA, and he didn't want to approve or to release the body until he pay a certain amount of money. That is a challenge that we have received. So that one, in our side, people may think that we have collaborated between the facility and the other one for us to achieve something that is not right. So I just want you to assist us. Sometimes do something practically. If she have cleared the bill, just release the body. And then, whenever we are registering people think that because I have no new, so I have a high chances of giving you a high chances of paying the money when registering. So we find it is a very big difficult for us, or we have a blame to be blamed. It is us who we are doing all these things to favor some families, because one comes, our family is being paid 300. Ours, how comes this one is paying 1,200 or 800? Or do you have side effect that determine who is who between the two? So that is a challenge that we have. So we are requesting SHA, even though it is systematic the way we are conducting, kindly can you go and reapprove so that we have a flat rate in rural areas. And those who are in payroll, let them pay whatever they want to pay. And it will be of a good idea, and we shall achieve all these goals together. Okay. Otherwise, I wish you all the best.
Thank you very much, Stephen. Valentine is here, and I can see her taking notes. We have a question here from somebody from the deaf community. Just just sit down and we can take the question.
Question once more. Another thing, people are requesting, if you have cleared the bill in the hospital, and maybe that client or anybody has died, why does SHA stand for people who are in mortuary? Because we are in the same facility, why does SHA stand for it or pay for it? So that because when you reach the mortuary section, you go and pay those money for mortuary section. But it is not inclusive in the side of SHA. SHA only finishes with medical, but they are requesting, because the body is still lying in the mortuary, and it is still the same facility, let SHA clear everything. And we are proud of it. Thank you.
Thank you very much. Stephen, Valentine, you'll answer those questions, but want to pick a question here from the deaf community, and then we have a gentleman here at the front. We'll take those questions, and then we'll take another round of questions. Okay, please go ahead. No, just sit.
Thank you so much for this opportunity, and also to the panelists, we appreciate you. You have really elaborated more about SHA, but now I'll start first by introducing myself. My name is Rosemary Saina, and I am representing the deaf community in Uasin Gishu County. So I have just two questions. And the first one, you find most of the deaf people, they do not understand about SHA due to communication barrier. And because there's no one who has come to us as the community to teach us what is SHA, to enlighten us what the government is doing when it comes to SHA, to tell us even how to register. So that is a gap that is there. And even to the community healthcare promoters, they don't know how to communicate with us, because I wish they could have employed a deaf person who can be part of the community healthcare promoters to have a one-on-one communication with the other deaf people. So we would request if we can have some deaf people trained, like a TOT to be trained, and then once they are trained, they can go and recruit other deaf people to register for SHA. Number two, on the community also health promoters, you find most of the time, they go, yes, to families, but my question is, how do they communicate with the deaf people? Because I remember there's one time they visited our homes, and the only way we used to communicate, it's through writing. And remember, not all deaf people are well educated. So I feel it will be great, either the healthcare promoters also to be trained on sign language, for them to be able to communicate with us clearly. Because we know healthcare is very paramount to everyone. And there are different sicknesses out there, and we need to know how we can access these services. And I know they usually experience those challenges. They can attest that. So that is my question. Another one, I want to appreciate the team, the panelists, like Mama Ruto Hospital. It's a very nice hospital. But for me, I know the hospital is in Uasin Gishu, but the other hospital, the main hospital, the public hospital, it's not, they don't give us good services. You get to the hospital, and the doctors, they have very negative attitude towards us. They are talking to us directly, and they are not, and then they say, you have to pay. And then for me as a deaf person, I'm like, why are you giving me bad services? So I feel Mama Rachel has been doing a good job, but the government hospital, there are so many challenges. They tell us even come with a friend who is going to assist you. Come, and when you want to do any test, you are told you have to pay. When you go to the pharmacy, you are told you have to pay for everything. Yet, you people are saying SHA is working. So those are my questions.
Thank you very much, Rosemary. We'll take those questions, and then we'll come to the gentleman here. Let's answer those ones first, and then we'll come to you next. Valentine?
Thank you very much for those very good questions. We left out one from Limo initially about dependents, that one has an 18-year-old dependent who is not working. So to answer you, Limo, and all of us who are here, is that SHA is able to cover dependents up to 24 years, as long as they're still in school. And you register as a parent, then you put your children as your dependents. The only thing that happens for an over 18 is that you have to register them but not do means testing. Then you add them into your cover. But you don't need to do means testing for them to pay premiums. I hope that is clear. So Limo, you don't have to worry that your son has to pay separately. The same cover for the parent covers the child. Then Limo also asked about procedures that are offered, that in private sector, they are expensive, and in public sector, they are not. What you're saying is that the benefit package is a standard package. We reimburse same amount for same procedures, be it in government, be it in private. So in private, you may be asked to top up, and I think she explained something. But in government, you're not supposed to top up. So it's good also for you to be informed on choices to make when you're going for a procedure. Sometimes I notice that most patients do not get to know that information. Then after the bill is out, that is when they get stressed because they're asked to pay on top of that. So it's always good to discuss with your healthcare provider that SHA, yes, will approve what will happen, so that as you accept to be treated, you are aware in advance that this is what will happen. But we reimburse the same amount. If it is like hip replacement, we reimburse up to 300 and something thousand for both private and public facilities. So there's no difference. We reimburse equally, and I believe I even have my colleagues here who are with me, and they can confirm that. So about awareness, there's someone also who asked about awareness, Machuka. If you notice, since SHA started, there's a multi-sectoral approach to disseminating information about SHA. Apart from SHA itself, we've even partnered with county governments. We've partnered with even our CHPs, even with cooperative societies, even with hospitals who are our stakeholders in ensuring that we give out that information about SHA. And we even, in every forum that you see happening, even within and even outside Uasin Gishu, we are always there having a desk. And even all our healthcare providers, there's a desk that is able to give information about SHA. So about awareness, we are doing the much we can, and I believe we can still do more. There's still room to do more. If it is road shows, if it is going door to door, I think that is where we are heading to. But we are able to work together to have everyone get to be aware about SHA. My colleague here, representing CHPs, the community, about mortuary fee. SHA, mortuary fee is part of the package, but it is yet to be rolled out. When SHA came in, there are benefits that were rolled out immediately. There are some who are to mature after 1 year. So mortuary fee is one of them. It will be able to mature very soon, and you'll be able to access. It is part and parcel of the benefit package, but yet to be implemented. So the good news is that it is part of it. Thank you, Rosemary, for your good question, a very touching question, and I want to say that it is an area that we must consider, because communication is very paramount. There are our people in the community, and without proper communication, they'll not be able to understand SHA. So it's a feedback that I'll give back to my seniors, the need to have people who are able to communicate using the sign language. As SHA, we have very few employees who are able to communicate in that language. So it is a challenge to us, and I will take it positively, and that feedback will be relayed. She also talked about bad services at public and government hospitals. I think my colleagues here will be able to talk about that. Thank you.
Thank you very much, Valentine. Dr. Korir, you can pick from what Rosemary was speaking about. How do you, as facilities in the county, help with the communication with people from the deaf community? And especially because some things that bring people to hospital are very personal. You may not want an interpreter in there. So what happens in these situations, and how can it be made better? And I was seeing many people clap CHPs to be taught sign language. Is it time also that your doctors and nurses learn sign language so that they are better equipped to offer care for such a group of people in Kenya?
Right. Thank you for that question. Allow me to sort of divert slightly. I want to invite one of my fellow facility managers to speak to the inpatient matter. Because I remember
we'll get to him. We're just sorting something technical.
Okay.
We'll get to him.
All right,
yes,
good. Because
yes.
I think it's important that she speaks to the inpatient aspect.
Yes.
We deal mainly with maternity, so I may not be able to comment much on that. So it's important that she speaks to that. So on to Rosemary's question. Thank you so much, Madam Rosemary, for that. Unfortunately, as a society, we tend to leave the less abled behind in a lot of the services that we offer. Besides just the deaf, also the disabled, in as far as accessing certain areas they may not be able to access because there are only stairs, there are no ramps. Unfortunately, this place is also a culprit. I don't see any ramps anywhere for disabled people, so I don't know how they are going to access the seats. On the matter of deaf patients, I am sorry, Madam Rosemary, for what you and your colleagues experienced in the facility you mentioned. I would like to speak for Mama Rachel. Mama Rachel has actually delivered quite a number of deaf people as well. Delivered deaf people who are mothers who are deaf, let me put it that way. And we have experienced some challenges, and you brought that to our attention now, and I think now that you're representing the CHPs as far as deaf people are concerned, I would like to invite you to bring deaf mothers whom you are involved with to come and deliver in Mama Rachel Ruto in your company. I think that will be able to help us also bridge that gap in as far as how do we communicate with them. And I think you'll get the service that you deserve at Mama Rachel Ruto. Let me add to that, we've also introduced an audio-verbal clinic in Mama Rachel Ruto Hospital. Every week we have at least 50 people receive testing or an assessment of their hearing capacity in Mama Rachel Ruto. We have extended the same to babies. The moment that they are born, we're able to assess the babies on their capacity to hear. So that is one way that we're trying to bridge that gap in as far as babies and possibly having hearing deficits, and also adults who may have not been diagnosed with a hearing impairment. And so we're offering that service in Mama Rachel Ruto free of charge. We have technical individuals who come every week to provide that service. And so I think that's what I can be able to respond as far as that particular question is concerned. Thank you.
Thank you, Dr. Arian, thank you for the information. It's good to hear that you're doing the neonatal hearing screening to pick hearing impairment early. Sharon, on the issue of, what was it? Yeah, helping people with disability to access services in your hospital.
I think I agree with Rosemary and the part that she says healthcare workers, we are not sensitive with the needs of the deaf or the blind. You find that most of us have not been sensitive to making sure the people who are blind, we have the braille and things that they can read, and for the people who are deaf to have a translator. So I think for me, I'm going to take it as a lesson for my facility and hire someone who can at least translate for them, because with this era of data protection, having someone else who will hear her private information that she's not supposed to, we should not be allowing that. So forgive us, and I think on behalf of the private sector, we'll try to do better.
Thank you. Sharon, we will follow up to make sure you've hired that person. We are ready for your question now.
Okay,
Just keep seated and you can ask the question.
Thank you very, very much, panelists. Thank you very much, Dr. Mercy. My name is Dr. Elvis Chirchir. I'm one of the sub-county health coordinators in Wazingishu, a sub-county called Kapseret. And I also double up as the head of health products and technologies. I have a testimony about SHA. Personally, I contribute through my salary 2.75%. Actually, when I looked at my payslip in October I almost got depression because 10,000 of my salary was deducted. But after I reflected after a month, and I said that money benefits another human being who is not able to have the privileged job that I have, I went to church and celebrated SHA. Question, maybe a little bit of three questions that I have. One, to Valentine Morogo. This morning, we had a high-level visit from the USAID regional director from Washington, D.C., and a team from country office. And they were coming out to look at the continuity of support from the U.S. government in health in Wasingishu and the feedback. And when I reflect, there is a section of our clients that are HIV infected, that HIV is a chronic disease. They have to take lifelong ARVs. They are prone to get TB. They are prone to get other opportunistic infections. There is what you call even advanced HIV disease, that patients that have CD4 of less than 100 can develop toxoplasmosis. They can develop a typical pneumonia that's called Pneumocystis carinii pneumonia. They can develop a lot of bacterial sepsis. They can develop Kaposi sarcoma. They can develop so many complications. What is SHA intervening? Because these are the very vulnerable members of our society. HIV programming in Kenya under NASCOP, I don't know how you are leveraging on the existence of people like Ampath that run North Rift. And two, just a clarification, you said you've enrolled over 18 million populace in Kenya, thereabouts, and then you mentioned a data from Wasingishu. You said 1.4 million out of 5 million. I stood back and said, I thought the population of Wasingishu is 1.3 million, the entirety of Wasingishu. Where are you getting the 5 million? Third, as healthcare professionals and as people who pay 2.75% of our salary, we used to pay 1,700 under NHIF. Now, everybody is gobbling with 2.75%. All salaried people in Kenya. If I use myself as an example, previously I used to get under all NHIF, I used to get yearly 50,000 for my dental services. I used not even to spend anything. It used just to be in under. Right now, you reduce to that 2,000 shillings. And I access, because I'm a KMPDU member, I access comprehensive NHIF cover. Comprehensive allows me to go to Eldoret Hospital. I've actually exhausted my outpatient cover because there's a day I just went for medical checkup. I went to do my abdominal ultrasound. I cut a 30,000 SHA paid. There's a day I went for 1, 2, 3, 4. I've exhausted the 250,000 outpatient cover. I'm now, I don't know whether when I fall ill tomorrow, I will have to fundraise. The doctors here will have to fundraise for me. My question is there going to be a review to allow us, because paying, if I show you my payslip now, I pay 9,500 for SHA. Is it fair to give me 2,000 for dental and no allocation for ophthalmic? I want just, this is a general comment. Those are my questions, Taksari.
And as you make the comments, Dr.
Oh,
Korir wanted
maybe
you
to respond.
comment on, yes.
To respond. You want them to respond?
No, Dr. Korir wanted you to respond on the issue.
Oh, it was.
Okay.
I'll hand in the mic to when I finish.
Okay.
I want to laud Willow Media for the good work that you've, this journey, because I've been following Dr. Mercy Korir on KTN TV. When I was rushing to this meeting, I thought, oh, KTN and live, I'll be privileged to be on live TV today. But Kumbe, it is a social media. It's a worthy initiative to have conversations that touch lives. You know, life is sacred. God programmed man and said, we are created in the image of God. We need to preserve life, and we need to do every effort to ensure that our healthcare system is up to the, as per law, highly, they say, to offer. It's actually universal health coverage comes from even United Nations to say health for all. The goal is health for all. My brief comment is SHA is working. I'm a testimony. I'm a living testimony. I've exhausted my patient cover. So I don't know, you'll review, is it calendar year or you'll review it in July? Respond to that. Thank you very much. Let me hand in the mic to.
We'll get Valentine to respond and then we'll come to you. So Valentine, please go ahead.
Thank you very much, Daktari, and thank you, Daktari, as well. Yeah, I will start with the second question about registered members. When I introduced myself, I said I serve North Rift region. So the figures you had about 1.4 is for the counties under North Rift region. And these are 7 counties, beginning from Uasin Gishu, Trans Nzoia, West Pokot, Turkana, Elgeyo Marakwet, Nandi, and Samburu. So the 1.4 is the total registered members for the 7 counties. But for Uasin Gishu specifically, we've registered 412,466 members, or a population of that, out of a population of 1.16. So she'll get that clear. And we are at 35% in Uasin Gishu County. So about HIV-infected clients, they are not discriminated as well under SHA. Those opportunistic illnesses that come, they are part and parcel of what is covered. Maybe on the ARVs, maybe that is where there still needs to be a discussion. But on those other opportunistic diseases, I don't think they are discriminatory, or the mama in the village is contributing through means testing, or the mama in the village is contributing through means testing, and what you are contributing through your 2.75% goes to the same pool. And that pool is where we access care, all of us, including the mama mboga. So if you're paying more and she's paying less, when you're accessing care, that is your money and her money is combined together, and it pays for their medication. So, and that is where the SHA is coming, because those who are advantaged in terms of ability to pay are holding those who are disadvantaged. So that is the social insurance, the aspect of social insurance. So about your exhaustion of limits, I said some civil servants and even some private organization employees, they have an extra cover over and above what we are given as the national cover, which if you exhaust, then it is a different arrangement, which now it is your employer and the service provider in terms of insurance cover provider who will be able to discuss and see how you can be assisted. So that is the much I can say about that, and we can still carry on the discussion on one-to-one basis. So I think those are the 3 questions that I was to respond to, Dr. Ari. Thank you.
Okay, thanks.
Dental. So about dental, the benefit package for SHA, for all Kenyans, that is the allocation that is given for dental. And as I said, there'll be a review as we progress, because feedback is paramount. So if we are saying that that amount is insufficient, then we take that feedback. And I believe there's a committee that has been formed to review the benefits package, which those are the feedback that will as well give back for consideration. Thank you.
All right. Thank you, Valentine. I want to take the questions from online, but before that, I'll give the lady here a chance. Tell us your name and who you represent, and then you can quickly make your comment.
Thank you very much. My name is Caroline Chemoiwa, facility in charge, Uasin Gishu County. I just think my colleague wanted me to affirm that the counties, we rarely charge anything on top of SHA unless a client has exhausted the cover. And on very rare occasions, do we have clients who have exhausted the cover. And SHA has a lot of benefits because of the fast pre-authorization that happens as compared to the previous cover. And also there are increased remunerations as compared to the previous cover. For example, we had a patient operated on for total hip replacement and total knee replacement, and the client had requested, we had pre-authorized during the time that there was still NHIF, and we were approved for 160,000, but then the client declined for the operation. Later on, when SHA took place, the client was operated on and we were paid 240,000, and the client did not top up anything on that. I just wanted to ask a question to SHA on the HIV care. As much as you have said that SHA covers opportunistic infections, there are times when HIV positive clients do not actually have the opportunistic infections, but they need periodic laboratory tests, which is not covered because the client was not sick, but probably after 6 months, they need some laboratory testing to be able to assess their level of viral load and, of course, as part of care, which is not covered. We do not see in SHA. I think that is a gap that needs to be looked into. Otherwise, we really appreciate SHA. There are a lot of good things that happen. Thank you.
Thank you very much. Valentine, you can pick that. And as you do that, Dr. Korir, I have a question for you from online about your thoughts on how SHA can ensure sustainable revenue, considering that patients make or clients make payments only when they know they are sick and they need to access care. So we'll start from Valentine and then we come to you. And then I'll ask the other questions as we go along.
Thank you for your compliment. And I'll say that I take note of what she said about the periodic lab tests. I take note of that. Yeah, thank you.
Yes, Dr. Go ahead.
Thank you for that question, Dr. Generally speaking, human beings have a poor health-seeking behavior. For instance, if I fall down today, I'll hesitate to go and get an X-ray. I'll limp on that foot until I'm unable to walk any further. At that point is when I'm going to go and get an X-ray. So it's just human nature to want to go for, to get insurance cover, for instance, when you do not need it. So I think that is where the government is really trying to encourage the members of the public and through our CHPs who are doing a very commendable job to register. Registering is free. And at the point where you're going to seek this medical treatment is when payment will be made. And I think I also want to appreciate SHA for allowing that access to happen as and when that payment is made. You don't have a situation where, like other medical covers, private covers, you have to have paid several months in advance before you're able to access this medical care. And so I think that's where the government is really trying to encourage everybody to be able to register for SHA. On the matter of sustainable revenue, unless we all play a part as members of this country to be able to help SHA, as Madam has said, all of our collections go to a pool. And that is where you and me are able to access this healthcare from. So unless we all play our part to contribute towards that, it means this SHA will not be able to function effectively. So my only appeal would be, Dr. and to the attendee online, is to encourage us to register for SHA. Thank you.
Thank you. Thanks, Dr. for your thoughts on that. Next is to Sharon. And here is just wondering how you attend to civil servants who are, under the managed scheme when they come to you, or they are the managed fund when they come to your facility seeking healthcare services, because SHA can only pay so much, and
they have a certain managed fund that they need to be to access their care from. So how do you manage them in the private facility?
For us, for the managed schemes, for outpatient services, we're able to pre-auth for their medicine, for anything that they need. So for the most part, the civil servants do not have to co-pay anything, because they have a package that, so long as they have not fully utilized the package that they have, they're able to get all the services without co-payment.
Mm-hmm. Okay. Yeah. And then this, I think all of you can answer this, starting with yourself, Sharon. How can the SHA benefits package include coverage for critical rehabilitative services, such as occupational therapy, physiological counseling, and physiotherapy? And this is a question also that has come up in our previous town hall, because this viewer said these are omitted, limiting access to care for the vulnerable persons, especially children and people with disabilities, both physical and mental. And we've had a lot coming up for people with disability. So can this be done such that these therapies are covered? So we can hear your thoughts, Ruben, and then we finish with Valentine.
Okay, I think personally for me, what SHA has been able to achieve now, I think, is equality, to where everyone is able to get the same cover, whether in private or public. But for us to get that equity that Dr. here was talking about, for the employed, we have to agree that we'll probably have to pay more, so that, I know you're saying 2.75% is a lot, but for us to be able to provide that care where everyone gets dental, optical, the physiotherapy, and to where everyone is not having to co-pay anything, our premium needs to go up to probably 7-point-something or 8%. That is just the truth, because the cost of healthcare is expensive, especially now when you look at the uptake.
So should because this is contrary to what Dr. Ricorero was talking about, should the premiums go higher, or should the pool of people contributing increase, so that you have more little kidogo kidogo from everyone feeling? So because if it's higher per person and there's a pool that's not contributing, don't you think that will cause certain problems for certain people who may not be able to pay?
I was still going on that. So looking at now, we have 55 million Kenyans, only 22 million have registered. And out of that 22 million, I don't know how many are contributing monthly. So if you look at it, and the insurance uptake behavior of Kenyans, typically you'll only pay when you want to use the cover. So there's a lot that we have to do to where we can get that equity cover, or the care that the patients need. So one option is for the people to pay more, the ones who are able, so that we can subsidize the ones who cannot. Or for everyone, like we have said, it's mandatory, but when something is mandatory, we are not happy with that. Mm-hmm. So getting that medium is extremely difficult. But I've had an opportunity to have been abroad for a while. So I know how those countries are able to manage their healthcare. People pay for it. They pay. When you look at countries, it's deducted automatically at 10% for when you're old, you have healthcare. So long as you know that when that time comes, you'll get the care that you need. I think for us, we have that low faith in the system, to where, like right now, you're paying a lot, like he's paying a lot, but when it comes to a private facility, we'll ask him to pay. So why should he contribute more when he knows that he's going to come, the facility of choice that he wants to come to, he's going to be asked to pay? There's no incentive for him to pay more. And then for the ones who are registering, you are being asked to pay more and you know you can't. And you know someone else who can pay more and is paying less. So you see both ways the system is somewhat not working for us, but it is us who make the system. right? So it is a part where we can make a conversation and just be honest with each other. If you want the system to work, we all have to make the system work.
Thank you, Sharon. Let's hear from Dr. Korir on including rehabilitative services and therapy.
Right, so remember SHA has been active for only 7 months. And just like any system, you need to remove some hitches or glitches as you go along. I think, at least from our perspective as a facility, there may be some services that may not be covered by SHA, but I believe that is for a reason at this point. Perhaps they want to iron out any kinks that are there in the system at the moment before now introducing more services. I think Madam Valentine will speak to that. On the point that you raised about contributions, I believe the more accessible something is, the more people will be able to access it. If the fruit is lower, then more people will reach it. By increasing the amount that you need to pay towards accessing healthcare, it limits the number of people who can access it. So my appeal would be, those of us who are yet to register for SHA, what is the reason you have not? You can be able to benefit from it, as myself and my colleagues have spoken to the benefits of it. Let every one of us live here knowing that, in fact, this building has SHA. Madam is on 7th floor. I think you can be able to register even as you live. So that the more people that register, the more it will be able to benefit. Thank you.
Thank you. Madam Valentine?
Thank you. I want to echo what my colleagues have said. But before that, I'll start by saying the benefit package that we have now is not cast on stones. And I know as the government works together with us in achieving universal healthcare, I believe in the long run, all these will be inclusive, but just a matter of time, because everything has to be planned in terms of budgeting and so on and so forth. So I want to say that these in the long run will be included, but it is not there now. So, and all depends also on finances, and as we have said is that those who are more capable should be able to support those who are not capable. And the spirit under SHA is that everyone must register. And what we are seeing now is that as we look at our figures, we are at 35% in Uasin Gishu County. Ask yourself, in your village, what is the percentage? Even as you, Daktari, in your village, what is the percentage? And if it is 1%, that means we are losing out, because there are people who are able to pay in that community or even in that village. And if they pay, and even in my village, if they pay, definitely will be able to introduce some of these packages. So it is an all-inclusive approach where we should all embrace this, because a pool is about all of us. So I call upon all of us to encourage all our people to register. We've noted in our figures that some register and they don't do means testing. People decide to run away from that. We've even had complaints from the grounds where people are registered but no means testing. I think CHPs can confirm this. People fear doing means testing because itawaletea 1,000 na wanaogopa. But if we all fear, who will take care of these things? When will we include these things that are not there? So my call is, let's register, and I know some are able to pay, but they just fear registering and doing means testing. Let's not fear. Let's embrace this, because it is our responsibility as Kenyans. Thank you.
Thank you, Madam Valentine. I want to take the final round of questions from the audiences here. Please raise your hand and we'll be able to do that. We have a question here from the deaf community. We'll take that first right now from the deaf community, and then we'll also now take the final round of questions from the audience here. And as we get ready for that, there is a question here, and I'll pose it to Stephen, and probably Valentine, you can comment on it. And this is from YouTube, that how can the community health promoters benefit from SHA as they are championing SHA in their community around the country? This is from a senior catechist, Serum Tui. Tembelio from Moiben. So how do you think CHPs can benefit? And Madam Valentine, you can speak to it, and then we'll take the question from our colleagues from the deaf community. And then we'll take the final round of questions.
Thank you for that questions. That is also the question that I should ask it. I will refer to Valentine, because he's the one who will give us the direction, because we as community elder promoters, we have done a lot to assist you as agents, and want that I should ask you, since we start registering, first we go for training that we were not paid by SHA. Yes, that is another one. And then secondly, what benefit are we going to gain, we as community elder promoters?
Okay.
Yes.
Let Valentine answer that very quickly, then we take the question from this side.
Thank you, Dr. That's a very difficult question, but I'll try my best. How can CHPs benefit from SHA? I'll start by saying it's, of course, a privilege for you to assist in the society. And through that as well, you are empowered because you are trained. And that training, I believe it has some value in your life and even in impacting the lives in the community. Secondly, I know that it's the county government who are hosting the CHPs. And the little I know is that there's some stipend also that they benefit. And he can confirm. But I know it may not be that sufficient, but I want to encourage us that the future is bright and something good will come up. Thank you.
Thank you, Valentine. Let me take a question from this side, from the deaf community.
Okay, thank you so much for the opportunity. My name is Marlon Kipchumba from Wasingishu County. I want to appreciate the panelists for the good job you are doing, and also to appreciate Mercy for this initiative. So I wanted to know, for us to get the disability card, we have to go for audiology tests. And this audiology test, we pay 1,000 shillings. Can it be covered by SHA to take those tests?
Thank you very much, Marlon, for your good question.
Mercy, can we also take this one?
Okay,
we are
very
done.
quickly.
Okay. Yeah. So my name is Martin Kamau, and I'm from Wasingishu County, and I represent the deaf community. And thank you so much for inviting us to this meeting. We really appreciate it. And I wanted to know, we as the deaf community, how can we be getting this information? Because we have always been left behind. Even when you check the website for SHA, there's no information there's no videos that show a sign language interpreter explaining to us more about SHA. So I wanted to know, how are you going to assist us? And most of the time, because we are always left behind, we also ask the community health providers, you can get us deaf people to train you on sign language. And also, most of us do not have job opportunities. So at times, it becomes very difficult for us to pay for SHA. Some of us have registered, but we are not able to pay the monthly contributions. And at times, you find a person like me, I have a wife, and I have to take my wife to the hospital probably to deliver, but SHA is not covering such. Probably is it because I have not paid for membership for the monthly subscription, or what could be the issue? Thank you.
Thank you, Minnie, for translating that to us. Thank you, Martin, for your questions. And I think it's coming out very clearly that the deaf community needs to be considered, and more importantly, SHA needs to be as inclusive as possible. And we'll get to answer those questions because we have the right people in the hall. So we'll get the questions from the audiences. We'll get a final round of questions answered, and then we can bring this to a close. Please go ahead, tell us your name and who you're representing.
Okay.
Thank you.
Okay, good evening, everyone.
Good evening.
My name is Gilbert Koskei. I come from Soy Ward, Soy Sub-County. I'm a CHP. First of all, I want to take this opportunity to thank you, Dr. Mercy Korir, for this event, because we have come here to learn, interact, and share. My question is that we all know about the defunct NHIV, that when you default you default from paying for some times, and then when you want to use it, there is a penalty that you have to pay for it to mature. My question is it also applicable for SHA, that you are in the system? You heard our chairman talking about we have registered many members of the public to the system, but they haven't paid anything. So does it mean that when they want to use it, are they going to pay the penalty fee, or are they going to pay the accrued amount that they haven't paid for some times when they registered? That's my question.
Okay, all right. So let's answer those questions as we get the other people ready to ask to answer their questions. And as we talk about penalties and whether audiology tests are covered, we have one question from YouTube. Somebody is asking you specifically, Madam Valentine, about ICU, where SHA says it pays up to 10 days. So does it mean if somebody stays in ICU beyond the 10 days, then they have to incur those costs and pay out of pocket? As you answer the question on audiology test and getting information to the deaf community via SHA.
Thank you once again, Dr. The first question was on getting the disability card, that there are tests that are supposed to be done for you to get that card. I will say that I will take this as feedback, as request for inclusivity. Yep. Because, as I say, the benefit package is still work in progress, because there is some review that will come. So this is something that will need to be included. But I also want to hear from our healthcare providers who normally do, what do we do when they come? Because I don't think it's something new. They must have come to our facilities. We also need to know what are these tests that are being done, so that can it be covered under our outpatient package? Because in our outpatient package, there are categories of things that we cover. So if it is part of that, then it should be taken care of under our outpatient package. So I will also need to work with the representatives to get to know, is it part of what is covered under outpatient? And if not, it's something that needs to be included, and I will give that feedback and recommendation. Okay. So Kamau asked about how can the deaf community get information. He also said that in SHA website, there's no sign language interpreter. It's a very good observation, and for sure it's been left out. And again, I will convey that, and hopefully this will be considered.
The issue of penalties?
Yeah, the issue of penalties, yes, NHIF had penalties for late payments. SHA equally, according to the Act, you're supposed to be penalized for late payment. If you look at even employers who remit beyond the 9th of every month, they're supposed to be penalized at around 2% penalty rate. So equally, it should apply to even the normal contributors. But as of now, I think the system has not yet captured that, but it should be able to capture. So my appeal is that let's pay our contributions every month to avoid the penalties, because the system, if adjusted and it picks the late payments, definitely you'll have to pay that penalty. So you better be safe, pay the penalties, pay the premiums on time. There was a question on, it was still Kamau asking about taking the spouse to hospital and the wife was not covered. When you go to primary care network, as soon as you register, you're able to benefit. But if you're referred to the next level, level 4, 5, because there are level 4s who do not offer primary care network. If you are referred to level 5 or 4 who are not offering those services, then you must be a paid up member. So if you have not paid, then you'll not be entitled to services. So you must pay your premiums as soon as you are not being seen at the primary care network. In Uasin Gishu, I want to clarify this, that even some of the level 4s, all level 4s government hospitals in Uasin Gishu are offering primary care network, primary care services. All level 2, 3, and 4s, they are offering those services. So you can walk in, walk out. You don't need to be referred. So please note that, because it is very important for us to know. Thank you.
Two quick questions on that. Do the public know who is a level 2, level 3, level 4? Because we may know, but does the public know in Uasin Gishu that who is level 2 to 4?
Thank you. Maybe I can give just examples. Is it okay? So that we understand. I know some may understand, some may not. So we have dispensaries, we have health centers, which fall under level 2 and 3. Then we have sub-county hospitals, which fall under level 4.
Okay.
Yeah.
That's good enough.
Thank
then
you.
my other question was on the penalty. Is the penalty a percentage or monetary, or is the penalty that they will not be able to access services if they are not paid up with their premiums?
The system will be able to show whether the premiums are paid up. And if there is a penalty, it will show that it is not paid up. So you have to pay for that penalty. 2% of the defaulted amount is what you will pay as penalty. Then the cover should be active.
Okay. I want to pose a question. Okay, we are ready with a question here. We'll take this question and then I'll pose some more from online. Your comment or question?
Okay. My name is Tom Boyolang. I'm coming from Kapsaret Sub-County, Langas Ward. Yes, Madam. Swali langu ni kuwa zamani wakati tulikuwa tumeanza registration Oktoba, ilikuwa tukiada independent ilikuwa nachukua. Hapa nyuma ilikuja kafungwa, sisi tukiada dependent aingi. Sasa tukiada watoto haichukui, inachukua spouse lakini watoto haichukui. So inabidi tuna register mtu na tunamwambia aende KVDA awekewe dependent ama aende kwa cyber. Cyber akienda ni pesa. Hiyo ni swali utatufanyaje? Lingine, inachukua watoto kuanzia 20 vile umesema tu yule amezaliwa up to 24. Niko na case mtoto alikuwa msichana alikuwa wa 19 years. 18 years. Baada anasoma mimba izui akakuwa mjamzito. Nimempeleka Mama Rich Hospital. Mama yake ako kwa SHA. Imesumbua. Ninaambiwa pale kwa Mama Rich Hospital ilikuwa kazi ngumu sana. Bahati mbaya alifanywa CS ndio akajifungua. So inasema SHA aitumii mama wawili, huyu sasa ni mama. Na aligadi bado ni mtoto ako kwa shule. Lakini bahati mbaya mimba hatukukataza kuingia. So kweli SHA haichukui mama wawili kujifungua. Kwa sababu mama yake ndiye aliregister kamweka. Na huyu sasa pia amekuja mama lakini bado ni ako kwa SHA, bado ni mwanafunzi. Ilikuwa kazi ngumu. Ako hapo huyu daktari anafikiri anaweza kujua huyu mtoto, mimi nilifuatilia huko. Swali la 3. Sisi community health promoters, we are agent. Muli to train October last year. Kitu ya kwanza, nyinyi kama staff, si mnalipiwa SHA? Mnalipiwa, mnakaviwa. Mbona sisi kama CHPs ambao tunafanya kwa ground, nyinyi ambao sisi ni agent, message ilikujia sisi, you are agent of SHA. Why? Mbona sisi hatukaviwi kama CHPs? Lengine, tulitrainiwa hiyo mwezi wa 10. Tukajaza form, lunch 500. Transport 500. Na tukajaza sio form ya county, ilikuwa Ministry of Health. Hiyo pesa mpaka saa hii inaenda kwa mwaka moja. Mnangoja nayo nini? Vile umekuja hivi ni vizuri. Hii hatuulizi county kwa sababu hii kwa form ya county. Lengine,
Tom, nitachukua hizo tu.
Ngoja kidogo tu.
Kwa kifupi basi malizia.
Lengine, tunasema hivi. UHC, ingawaje umejibujibu kidogo lakini haijakuja clear. Wakati wa NHIF, sisi tuliregister watu wale hawajiwezi kwa universal coverage ambao walikuwa wanalipiwa na serikali bure. Saa hii wale walikuwa na register na UHC, ilikuwa inatakana tukisha register kwa SHA, SHA iwachukue kwa sababu walikuwa ikue wanatibiwa kwa sababu walikuwa ni wale vulnerable. Walikuwa ni wale vulnerable. Elders. So SHA inaangalianga watu namna gani? Tukiwa kwa community sasa ile tunafanya registration. Unakuja ela imeshoot. Sina mengi, mtujibie hiyo.
Shukran sana Bwana Tom. Then we'll pick a question from up here and then we'll come to the panelists.
Thank you, Dr. Mercy Korir, and the panelists here. My name is David Tirop. I'm an employee with the Uasin Gishu County government, and at the same time, I work at the District Hospital, Department of Health. Now, I have a question, and at the same time, it's a comment in relationship to SHA. Now, when it comes to pricing of services and commodities, to me, I feel that it needs to be reviewed. In this context, you find, for example, let me go for drugs. A case example is anti-D, for example. It's one of life-saving drug when it comes to our mothers who are rhesus negative. Now, SHA only allows up to a maximum of 6,000 shillings. And the current price, purchasing price from KEMSA is 7,400 shillings. And with the current model we have, it means that we have, even in the public sector, we have to do kind of business. However much they normally say government don't do business with its own citizens. But at the end of the day, we have to gain profits, quote unquote, because services at the facilities have to run. What happens in such cases? You are still using a price of something that has changed. Maybe the price you quoted was 4 or 5 years ago, and the current price has changed, and you still stick to the same amount. What do you think about the facilities? So we are forced, the way private facilities do, let the patient claim the amount you allow, and then surcharge the patient on the difference. So it's you still find that the patient who comes to the facility will still have to complain that, one, I've been charged despite the fact I'm registered and paying my premiums. Another example is some services that are run in the lab. I saw even my colleague some other time quoting a certain reagent that they buy at a certain amount, but because of the charges they charge, you'll find that they are running at a loss. And at the end of the day, they'll be forced to charge the patient the extra amount that will be used to get the difference. Today, as we were coming here, there's a patient who was referred, who is, to me, I'm supposed to sponsor, went to MTRH because the test cannot be run in the district hospital. And upon reaching there, again, they say SHA does not cover this type of test. It's LFTs and UECs. So in such cases, what is the benefit of SHA to these clients? Again, it needs to be reviewed.
Thank you.
I'm about to finish. One last one. When it comes to issue of the comprehensive care, comprehensive cover, we used to get, before devolution, there used to be, all staff used to be, civil servants used to be from the national government. And the cover that was there was comprehensive cover for all the staff, civil servants. Now you find that after that, when devolution came, those people who were employed after 2013 or under devolution are disadvantaged. Because if you go to a private hospital, you'll be told that, like myself, I was employed by the county government, but I don't get the same service those people who came from the national government get when it comes to comprehensive cover. You'll be asked to use the other arranged insurance the county has arranged. To me, sometimes it fails. Sometimes the arranged insurance does not work. So what happens to that client who is deducted 2.75% and still does not get the same services as the other colleague who is still contributing the same percentage of from his salary? So I want to stop it there because of time. And also give it my
Thanks,
colleague.
Chirop. We'll answer those questions. We'll start from Dr. Korir, specifically on the question from Tom about a situation where a household has two mothers, one of them being a teen mom. What do you do when they come to the facility? Before we come to Valentine.
All right, thank you for that question, Tom. It has actually been, we've had quite a number of experiences like that. We have a lot of underage mothers, unfortunately, that is below the age of 18. So we got into an arrangement with SHA, whereby, and I believe Madam Valentine will speak to this, the underage mothers are given a temporary sort of identification. I don't know what you call it, that's how I remember it, whereby these mothers who are underaged are able to be registered separately, not under the cover of their guardian or their dependent, or their parent, sorry. And SHA is then able to cover that particular service. So that's what we've been able to do at Mama Rachel Ruto. So Tom and anyone else, CHPs, we're not encouraging underage pregnancies, obviously, but let them not lack services for that reason. The mothers may have registered them under that cover, but SHA will not accept to pay that claim because it is assumed that this person is old enough to get pregnant. They are old enough to be able to have the cover, the services, or rather have themselves pay for the services. So that is how we're handling that particular case.
Okay. Sharon, what of your facility and the other private facilities? Is it the same, getting a temporary ID that SHA then takes care of their premiums and subsequent healthcare access?
I think this was something that was introduced recently by SHA. When I don't think we've had incidents, but we are aware of how it's supposed to be handled. And usually you communicate with the SHA office. The QA is usually able to sort the issue promptly. Yeah.
Tom, natumai kuwa umepata kujibiwa hilo swali. Wacha tunaendelea nayo mengine. Valentine, most of the questions from Tom were to you. Okay. On the challenge of adding dependents such that people have to come to the SHA offices, the issue of indigents or the vulnerable in the community, what happens to them, and then the questions from Tirop about pricing review, the comprehensive care, and the back and forth between facilities.
Thank you. I want to add something about the under 18, the 18-year-old mothers or the teenage mothers. The government hospital, especially MTRH, if they were here, they could really experiment what happens. But when SHA came in October, it was not able to take care of that. But after a short while, there was a way the system was adjusted where we are able to register underage mothers. We are able to use their birth certificates. We register them as a contributor on her own. They are given a CR number, which is like a SHA number, and the same cover will cover the child. As soon as the child is born, the child is added into that cover. So, Mr. Is it Paul? Is it Paul? Tom, yeah. It is now taken care of, and I believe Mama Rachel is also able to access that currently. In private hospitals, I think they are not, at the moment, they have not embraced that, but it's something that can also be embraced there.
Okay. So does SHA take care of the premiums, such that they are not asked to pay for premium?
At the moment, as soon as they register, they are able to access care without paying those premiums for maternity services.
Okay, all right.
But as soon as after that, they should be able to in future. So Paul said that in October they were able to register and add spouse and even children. Lakini anasema saizi hawawezi ku-add spouse, so they have to send people to the branch. So I don't know what's really happened with the system, but I need to check on that. So we may need to check on that. Please come to our office, we check on that, what could be the problem. Because if it was possible, then what has happened? It means maybe there's a problem with the system or the gadget, I don't know, but maybe I request that we look at that.
Okay.
I'll take it up.
Pricing review for commodities that Tirop brought up.
That is from Tirop. He asked about a review of pricing, like anti-D. Yes, it is 6,000 at the moment. During the pricing of the benefits, there was a team that sat down and looked at it, and maybe during that time, they were not able to really maybe get to know the escalation in pricing. And as I say, there's a team sitting now looking at the reviewing of the benefits, and this should be part of what we will give as recommendation. So this is noted, including the lab test that you talked about. I'll request that maybe we can also, as a county, if there's a way through your leaders, a proposal is written to SHA, even to the CEO, so that it can be escalated to that team, so that as we do the review, it is included, having gotten feedback from the ground.
Okay. Thank you. We'll take the last question from the audience, and then we'll pick 2 questions from online, and then we will bring this to a close. Please go ahead, tell us your name and your question or comment.
Thank you so much. My name is Titus Kiplimo. Link Facility Sambut, Kamagut Ward, given amount she's been given. One point is to Mrs. Morogo is that somebody was giving out an information that when it comes to payment of premiums, should it be monthly or annually? Because somebody was advising some people that you don't have to pay. If you pay like for 3 months, the system assumes that is your calculation, that is your monthly premium. So she was advising that people pay either monthly or annually. Can you kindly clarify to us so that somebody who has money to pay for 3 months can pay? Thank you so much.
Okay, thank you very much, Titus, for the question. So we'll get Valentine to answer this question. And we have 2 questions that I'll also just throw to you from online about, and I think this was very specific to Eldoret Hospital, but maybe it's something that happens in the other facilities. Can SHA consider giving one-time approval and a combined cost for heart tests and treatment at Eldoret Hospital when a patient shows signs of a heart attack, so that care can happen quickly without delays or out-of-pocket costs or payment? That's the first one. Then the second one is, if employers haven't made remittances to SHA, and we see this quite a lot with county governments and some other employers, I don't know if it's the case with Uasin Gishu County, yet that was deducted from the payslip, and somebody needs care, what happens at that point to resolve that situation? And I would want to also hear from the facilities. You have been deducted from your payslip, but it hasn't been paid up at SHA. What happens? And I'm at the hospital. So you can pick those 3 questions, and then we can close this.
Thank you very much. I'll start with Kiplimo's question that is it monthly or annual? According to SHA Act, it's supposed to be annual premium payment. But as SHA came in, it could allow even monthly payments. So I'll say that you can pay monthly, you can pay annually. The advice that you got, maybe it wasn't the right advice, but what I know is you can pay monthly, you can pay annually. I hope that is clear. Then a question from online, can SHA consider giving one-time approval? That's an Eldoret hospital case. I may need to get more details, but okay, it's like an emergency, I guess, that there's a threat of an heart attack, and maybe the delay in approval or okay, I'm not able to really get it clear, but every time one goes to the hospital and a request for approval is done, our AI is able to approve as soon as possible. And if there's a delay, the hospital has the responsibility to attend to an emergency case. I have a Eldoret hospital with us here. I don't know whether, Dr. There'll be need to maybe ask them to say something about the case. They might be aware of the details of the case. If you allow, I'll give them a chance so that they say the details of that case. But from where I sit, an emergency case must be attended to, even without approval.
Okay, we'll position them ready for that as we...
Then maybe I can respond to employers having not paid premiums and the employee needs to access care. Employees, an employer has the responsibility to pay for premiums on time by 9th of every month. And as SHA, it is our responsibility also to ensure compliance. And if an employer is not complying, there are procedures. One, there's a penalty. Two, even in the long run, there can be an imprisonment for that. So in case the employer has not paid, you as the employee, if you get to note that early in advance, we also request that you let us know so that we ensure that it is paid. And in a situation where you reach the hospital and it's not been paid, you can contact us as soon as possible. Then we contact your employer to have them upload, because the moment they just pay, we are able to apportion in your account immediately. Thank you.
Okay, let's get the response from Eldoret Hospital, and then we get to hear your experiences on employees whose employers haven't remitted on for SHA. Your name, please?
Okay, thank you very much. My name, I'm Samuel Yego from Eldoret Hospital. Okay, I wanted to thank that is the Willow fraternity for giving this as an opportunity to come and address. And I believe that once we address, we have that is the UHC, they'll be able to address that is in the ground. I want to say that our facility is level 6B, and I want to congratulate. Let's give a credit where it deserved. SHA has done good things. Like, for example, ICU. NHIV used to pay 2,500, but currently SHA is paying 28,000 per day. That is a good thing. Number two, we are doing that is oncology. That is both radiotherapy and oncology. And that is under the NHIV. We used to get that is 20 sessions. And it was 3,600 for radiotherapy. Right now it's open. Someone can be able to access the services. Number three is that about the cardia. I think we are doing that is the cardia, South and North Rift. Sometimes we are encountering challenges because specialized surgery is being done once per financial year. So that case, for that particular patient, I think that procedure was done on December, but unfortunately, it reoccurred. So the patient had come back for the second procedure, but we informed that that is the SHA approved specialized surgery once per financial year. So we advise the patients to register because the spouse, she wasn't registered, but we informed the patients that is the spouse to registered under the SHA, and she was being able to get 504,000. So generally, that is the SHA compared with the NHIF. We have seen good advantages.
Okay.
But the challenge with SHA is about the way Sharon has said. She has said it is about payments. Payments is an hectic, like surgeries, but SHA emphasizes that is in terms of payments for chronic, that is radio, dialysis, anything that is chronic. Number two about the challenge is that sometimes you are getting a patient maybe has got an RTA, and there are two procedures that need to be done. Maybe that is a tibia and a femur. So when we request one procedure, we get 100%. But since we didn't know that the second procedure is supposed to be 50%, so as we request 100%, so later we are getting that the information that the second procedure should be 50%. So kindly, I'm requesting the SHA community to address so that at least we can be able to get the information. Thank you very much.
All right, thank you very much, Diego, for your feedback. And I'd like to hear just from Ruben briefly and Sharon about employees whose employers haven't remitted and have come to your facility. What do you do?
All right, we've encountered quite a few such cases. Unfortunately, our hands are tied. Like I said, we will not deny service. Service will be given, but thereafter, unless we're able to have the claims appear active or the membership appear active, then we will not be able to claim. So we direct them to SHA to be able to now coordinate with the employer to have that one done. Perhaps I can speak for us as the civil society or public servants. I recall CS Duale spoke to this a few days ago, and I think he's been impressed upon to have the deductions done at source, so such that before our salaries are paid, the deductions are made to the respective, whether it's loans or SHA in this case, it can be done at source. That way we will not be able to encounter these delays in service delivery. Thank you.
Okay, let's hear from Sharon.
Thank you. I think on the issue of when a patient comes and their SHA membership is not up to date, it depends on the situation. Because for emergency cases, under the SHA package, the patient can receive services whether their membership is up to date or not. So if it's an emergency case, if their SHA is not active, we are able to provide service and transfer them to a government facility if they're not able to update their cover. For outpatient, because we accept patients under PHC, we are still able to provide service and claim under PHC, which the member does not have to be paid up to date. But for surgical cases, if the patient needs to access the SHA packages, they will have to ensure that the employer has made the contribution up to date.
Okay, so let's hear your closing remarks. We'll start with Stephen. What has come out clearly from the conversation is that there is some trust that still needs to be built between SHA and the community. What do you think you can do as community health promoters to be able to build trust between Kenyans that you serve and the SHA and even the facilities that are offering services so that we're able to move an inch closer towards universal health care?
Okay, thank you, Dr. Masikorer, for that. Mine is I want to request the members and community at large and leaders of Uasin Gishu County for sensitization on SHA. Because what I've seen, the rate is too low. 412 registration that we have done is still very low. I want to urge our honorable members to come up and support us. We go together for us to achieve our goals. Okay. Because there is no need for them to come when it reaches election, and they do their mobilization for them alone, while when it reaches sensitization of life to touches the life of our human being, and they depend on them during the next general elections, they come forward and say, you want to assist this and this. We requested them to come forward and be with us so that we go as one team for our people to have better health care for our future. Okay. Another thing, what I should request our Valentine, kindly, we have done something good for you people. You are an employee of SHA. And you know the stipend that we are being given does not worthy. And the workload that we are doing is really big. So we are requesting you also to see that what are you going to do for our community health promoters as the way how you will promote. It is either way you pay for them for 1 year for their premiums, or you give them, because there is a saying in Kalenjin that says, if you take it as a knife from a child, you give it a stick. So kindly, we requested that one for your office, through your office, to go and do something for that. Okay. Another thing that I request is through our doctors that are around with us and our CEOs, kindly come up and assist us, because while we are in the field, we are facing some problems, because sometimes you might find somebody, you want to dress a wound. It is a problem to us to do that part, because we have no knowledge for that, and there is no any sensitization that have been planned for that. Kindly come and assist us for that one, for us to know 1 or 2 things, because the kids that are being sent from national government, we have the things that are supposed to be done for wound treatment, but we have no knowledge about those areas. Another thing, I should say thank you, Mercy, for inviting us, and we request one day, one time, even us as we stay, pray for us to have a salary, not a stipend, even though we are getting older. Let our younger generation to come and benefit from this program, and we wish each and everyone have a nice day, nice evening. May God bless you all.
Thank you very much, Stephen. We come to you, Sharon, on your closing remarks. Please let's make them brief.
Thank you. I think for me, I'll have something to say to the county. I'm glad the county is here. I think with SHA, there is a PHC part of it that the county plays a part of in it. And I've been waiting to hear progress on the PHC board. I think there's a board that private hospitals are supposed to be part of. We have not had anything. And I think part of the problem why you're seeing a lot of private hospitals not taking a big part of the PHCs, because we feel like we are not part of the conversation. So I would urge you, if you can, when you go back, talk to the CEO and to the CC. Call us for a meeting, so we can have that conversation. And I think if you have private hospitals involved, these patients come to us. And if they come to us and the first thing we're telling them is pay, 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 the uptake is not going to change. So let us see how we can work together with that, so that we can increase the numbers of Wasingishu, because we have a lot of private hospitals. And I can tell you, most of them do not accept SHA outpatient because of that, because we've not had that conversation to see how we can take care of our people. So, secondly, when it comes to SHA, I think it's a good opportunity and a good package for our patients. I think for us, when it comes to SHA, the software is good, the pre-authorization is good, it's just a matter of the payment and a little bit of enhancement of the packages that you have had from the county and from the patient. So if you can at least make the payment time better, I think the quality of care that we provide to our patients, the cost, and all of these issues that we are having, we will not have. And when next time, when we have a meeting like this, we'll all be hearing mostly positives, and it will be better for our patients.
Thank you very much, Sharon. What I hear is a lot more collaboration between the private sector and the government, be it at national level or at SHA. Dr. Korir, your final comments?
Thank you, Dr. Mercy, the Willow fraternity, and all members that are present here. My gratitude goes especially to our CHPs. I'm grateful that you included the chairman on this panel. The CHPs are doing a remarkable job, and I'm grateful also to the national government for introducing this initiative. We, as a country, should be heading towards prevention and promotion. We have a large mass of people who, because of the poor health-seeking behavior that I mentioned before, are unable to seek treatment when the issues arise. And so we, at the tail end of service delivery, the level 4s, now receive these cases when their diseases or their conditions have advanced. And there may not be much that we can do at that point. And so the CHPs are playing a critical role to identify these cases at the community level. So I appreciate the CHPs for what they do. As Mama Rachel Ruto Maternity Hospital, we invite the members of the public to come and visit our facility. The first county maternity hospital, and named after our First Lady, Mama Rachel Ruto. And so we want to elevate the services that are being offered there. And the only way we can do that is if you're able to register for SHA. And that is where we encourage as many of us that are present here to register for SHA. We are offering SHA registration at our service for free, our facility for free. So those of you who are unable to access SHA or are being sent to cyber cafes and so on, please come and register with us, and we'll be able to offer you that service for free. Thank you very much.
Thank you very much, Dr. Korir. And last but not least, Valentine Morogo, your closing remarks, and definitely a lot more work for you as you go back to your office, as you go back, to your meetings with the other SHA leadership.
Thank you, Dr. Mercy Korir, for this opportunity. It's been a very interactive session, and I want to say thank you for organizing this important town hall session, where we've come together as Uasin Gishu County to be able to talk health. And as we are aware, health is wealth. So, and I'm looking forward to see that we have best health even in this county and even in North Rift at large. So I want to appreciate everyone because health is a collective responsibility. I do my bit, you do your bit, all of us, and we will see it work. If we keep saying it's for Valentine alone, it will not work. But if we say it's Valentine, it's Mercy, it's the county government, it is the private hospitals, we'll be able to achieve more together. So I want to request us that let's ask our people to register. I think I'd say that you are an ambassador. You are here today, and I know you have more knowledge than even that person in the village. So it is our responsibility, and I urge us that let's go and talk to them. I know there's a lot of negative perception pale kwa ground, but I want us that now that we know, and I know we knew even before, let's encourage our people to register, and they will benefit, and that will be a problem of the past. Our CHPs, we will work together. I request that let's work closely. I know if we come close to each other, we'll be able even to solve most of the issues that came up today. So in case there is anything, let's walk to our offices, let's work together, let's exchange contacts and make healthcare better in this county and even in North Rift at large. We appreciate Our Excellency the President for this idea. Let's support, and we are the first beneficiaries of this. Asante sana.
Okay. Thank you very much, Valentine. Let's give our panelists a warm round of applause for delivering, insightful thoughts, knowledge, and their own experiences that have enriched us as an audience that has been here. Thank you to the audience that has been here physically, KVDA Plaza for hosting us, and our audiences who have followed us online for your comments and your interaction. This has been a very interactive session, and that brings us to the close of Willow Lifeline Dialogues, live from Eldoret, the city of champions. Tonight, for us, was not just about policy talk. It was about voices from the ground, voices like yours, which have, in this stage, met decisions from the top. It was about that mother in Ziwa, the health worker in Iten,
and the border rider from Langas, all asking, is the Social Health Authority truly delivering for me and for us as envisioned? What we have witnessed this evening has been conversations that have been deep on health financing, on access to health, and there have been calls for clarity, calls for stronger implementation. It's clear that for SHA to work, it must work for everyone. And that starts with you speaking your mind. It starts from you staying informed and holding the systems and power that be to account. But it isn't the end, and it's just the beginning, and especially for us here at Willow Health Media. We ask you to join our online community at Willow Health Media on our various social media platforms. You can find us so that we keep this conversation going, we keep this fire burning. Our hashtag for the SHA conversation is Let's Talk SHA, because we'd like to continue hearing from you, and as we plan to go to another town to have this conversation, we want you to be part of that conversation. We want you to be part of that journey. You can subscribe to our YouTube channel so that you can access the full recording of our town halls. You can access our exclusive expert interviews and updates on all our upcoming niche content that address the matters that matter to you the most, which is on health. And until next time, I urge you to stay informed, stay empowered, and stay healthy. Thank you, everyone that has been a part of this production. My production team, my team from Willow Health Media, the team that has been doing the sign language interpretation, that is Mini Mbesa and Meresha Owiti, making sure that we are as inclusive as possible at Willow Health Media, because we've heard here today that we have to include the people with disability in all of these conversations. And we hope that we all can go home with that information that everyone matters, and for SHA to work, it must work for all of us, regardless of our race, of our abilities, and of where we are in this country. I've been your host, Dr. Mercy Korir. Good night, Kenya.
Thank you so much, Dr. Korir. We have come to the end of the program. Shukran sana. Thank you all for coming. Thank you all for participating. Tafadhali tujipigie makofi kidogo. Tumefaidi sana. Tujipigie makofi tena. Now, it is time we appreciate our panelists.